Okay,
Okay.
great. Thank you.
Mhm.
All right. We're going to start with respiratory diseases as our first presentation here. And of course, all the learning objectives for this session. At the end of this training session, the coder or specialist will be able to define pathophysiology associated with respiratory system, understand the coding guidelines associated with the respiratory system. We're going to also evaluate the query practice brief update from AHIMA and ACDIS. And there was another update, a little caveat that I did not update in our presentations because it just came out, I believe, a couple of weeks ago last month during the California ACDIS convention. And unfortunately, I was out of the country for the month of May. So just FYI. We're also going to review some case scenarios with common disorders with the respiratory system, and then go through some sample queries for most of the MCCCT capture diagnoses and any other trigger words associated with query opportunities. We're going to review ICD-10 CMS PCS coding updates for fiscal year 2024. That should be 2025 because we updated it to 2025. Sorry for that typo. And then Q&A. Like I said, with our Q&A, we can go through. If you have any questions, don't hesitate to stop me or Christy during the presentation. Our disclaimers, this is designed to provide tools for communicating information about clinical documentation, coding, compliance, and an educational structure. We are not giving any legal assistance or advice, but offer sensible and useful information and tools to obtain compliant results in the area of clinical documentation and coding. And the educational materials provided in this presentation are carefully explored for its accuracy and usefulness, and best practice results in achieving outcome will differ in each facility or hospital and or your clinical situation. So just keep that in mind. It's not one size fits all when it comes to coding and CDI. There's a lot of gray. So that's why it's important to utilize your knowledge base as nursing, coding, whatever the case may be. So let's talk about anatomy and physiology here. So when it comes to the respiratory system, we have the upper respiratory tract and then the lower, right? So our upper respiratory tract is the nose, of course, where the air goes through and from the lungs, and it filters out the impurity and warms the ear. And it's supported by your nasal bones and cartilage. Your paranasal sinuses, there are 4 pairs of the bony cavities that are lined with mucosa, and they have cilia, right? That is epithelial tissue, and that's where the impurities usually catch before going into our lungs, and then we develop pneumonia, right? So we don't want that. The other thing, the 4 pairs that we have of the sinuses are frontal, ethmoid, sphenoid, maxillary. Okay, and there's just a picture to add in there. The pharynx, of course, is our tube-like structure that connects nasal and oral cavities to the larynx, or also known as your throat. And then, of
Excuse me,
course, I'm sorry,
Anne-Marie,
what?
the
Yeah.
presentation is not advancing.
Not advancing?
Yeah.
Oh, we're still on the very first slide.
Uh-huh. Yeah. Can you,
Okay.
from the beginning?
That's weird. Are you seeing it now?
No.
No.
It's a slideshow, and then you click from the beginning.
Yeah. Okay, let's do it this way. I was like, everybody's texting me. What's going on?
Mm-hmm.
Trying not to interrupt you.
Everybody, I was like, oh, I see a text. I was like, okay, what's happening? Stop sharing. Okay. Let's try it again. Short picture. Share. I wonder if it, okay, you see the presentation?
Well, it's, and then check if you could go from beginning, that icon
Yeah, that's
there.
what I'm going to do. Hold on.
Okay.
All right. Can you guys see the respiratory diseases?
Yeah, but it's still
Slide,
not presentation.
Okay, hold on. I'm going to advance now. Okay, can you see the learning objectives?
No.
You can't see it.
No.
Okay, Christy, you're going to have to do it then.
Okay.
Because unfortunately, if it's not letting me share.
Hold on. Sorry about that technical difficulty.
Yeah, technical difficulties right now.
All right, let me just go here.
Thanks for the information. Unfortunately, I can't see the chat when we're doing the share as the presenter. So thank you for letting us know, letting me know.
Let me just open it and
Yeah.
okay, so respiratory. Let's do that. Okay, so let me go share. Let's see.
The arrow down over here.
Okay, hold
That
on.
little arrow is the share. There you go. Okay.
You see it?
Yeah.
Okay,
We got
so we're
the
learning.
slideshow. So, yep. So you
So we
want to
have the
do from
disclaimer.
beginning?
There we go. Oh, you cannot see it?
We can see the whole presentation though on the left panel, all the slides. So if you want to put it on slideshow.
It is on slideshow on my.
Oh, see, okay. Well, we're still seeing the slide deck on the left. All right. That's all right. Let's just do it this way then. I think we got to call Zoho and see what's going on. We'll give them a call, our platform people.
Okay.
All right. So anatomy and physiology, respiratory system. So let's go through this. Okay, next slide.
Okay, here is there we go. That's the
There we
one?
go.
No. Yeah, okay.
Yep. So next one. Okay, so anatomy and physiology, like I was mentioning earlier, our respiratory system has an upper respiratory tract and the lower respiratory tract. So your nose, of course, is where the air comes through, passes through the lung, and it filters out all the impurities and warms the air. And it's supported by your nasal bones and cartilage. Now, your four pairs of your nasal sinuses, your frontal, ethmoid, sphenoid, and maxillary, as you can see in the picture listed above, they're lined with mucosa and, of course, your cilia and the epithelial tissue. So they're also cleaning out the air for us. So we don't want to develop any, pneumonia or any other problems within our lungs. or any organism getting stuck in there. Your pharynx, that's known as your throat, right? And it's a tube-like structure that connects the nasal and oral cavities to the larynx. And then, of course, you have your adenoids and your tonsils located in the roof of your nasopharynx. And these structures protect the body from organism invasion. So you have quite a few upper respiratory tract organs that will prevent any infections, organisms, or just plain stuff going into your lungs. Next.
Yeah, it's the upper respiratory tract,
Yeah, went through it.
the larynx.
Okay. So here we go. So with the upper respiratory tract continuing, the larynx is also known as your voice box. And it is cartilage epithelial aligned organ that connects the pharynx and the trachea. So in this voice box in your larynx, you have several structures. Your epiglottis is the flap of cartilage that covers the larynx during swallowing. You have your glottis, or the opening between vocal cords, which is the opening between the vocal cords and the larynx. And then, of course, your thyroid cartilage, which is the largest cartilage structure. And this is also forms part of your Adam's apple. Your cricoid cartilage, this is the only cartilaginous ring in the larynx. Then you have your arytenoid cartilage, and this is for vocal cord movement within the larynx. That's how you get your voice, your sound out. And of course, with the vocal cords, your ligaments that control the muscular movements within the larynx, and this is located in the lumen of the larynx. The major function of the larynx, of course, is vocalization, right? This is how we talk, besides protecting the lower airway from foreign bodies entering your lungs. And then, of course, your trachea is your windpipe, right? This is all smooth muscle with C-shaped cartilaginous rings. And this serves as the passageway between the larynx and the right and left main stem bronchi through an opening called the hilus. So whenever you see, I always see hilus documented when the docs are performing a bronchoscopy, because they got to go through there in order to get to the lungs and the bronchus. Next. Okay.
No?
Next slide. Yeah. And
Yeah.
this is just pictures of the what we just discussed, the upper respiratory system and the different tracks that you can look at. Okay. We just like putting a lot of pictures in visualization so you can understand and just take a look at it. So it's helpful to visualize it. All right. And then our lower respiratory tracts. So we have the lungs, pleura, and the mediastinum. So of course, your lungs are peridoelastic structures found in the thoracic cage, with each lung divided into lobes. So of course, you're right, we have our upper, middle, lower lobes, and then left only has our upper, lower. Now your pleura is the serous membrane that lines the lungs and the thoracic cavity. And you have two membranes. So you have a parietal membrane, which lines the thoracic cavity, mediastinum, diaphragm, and your inner ribs. And then the visceral membrane covers your lungs. Last but not least, your mediastinum. So this is in the middle of the thorax, right between the pleural sacs that contain the lungs. Then in your bronchi, so your bronchi, there are several divisions, right? So we have lobar bronchi. There are 3 in the right lung, 2 in the left, and then they divide into your segmental bronchi. So you have 10 on the right, 8 on the left, and these assist with postural drainage. And then they're further divided into subsegmental bronchi. So they're surrounded by connective tissue that contains your arteries, your lymphatics, your nerves. All right. Then you have your bronchioles. And these are created from the subsegmental bronchi. These are where your submucosal glands produce mucus to line the airways. And then it is further divided. The bronchioles are further divided into terminal bronchioles and respiratory bronchioles. And these are known as transitional passageways to conduct the air and gas exchange between the lungs and within the lungs. So please note that there is 150 mLs of air that is not part of the gas exchange, and this is known as physiologic dead space. So our alveoli, or our little, the alveoli, that's where I was.
Mhm.
Alveoli, this is lungs is made up of 300 million alveoli. And there are 3 different types of alveoli cells. So your type 1, this is 95% of your alveolar surface area. And this is the barrier between the ear and the alveolar surface. Your type 2 is 5% of the surface area. This is where your surfactant and type 1 cells are produced. And then, of course, your alveolar macrophages, which is your third type. These are the cells that ingest any foreign matter and they protect the lungs. Okay, this is the defense mechanism to make sure that any foreign matters, whether it's organisms, dirt, sediment, whatever, gets in, prevents it from getting in there. And this is just a nice picture of what the lungs look like from the cartilage all the way through with your bronchioles. And there are fissures in here too, as you can see, your oblique fissure that I didn't really add into it. Okay. Functions. So what is it mainly? Oxygen transport, right? It removes the carbon dioxide in the blood and transport oxygen throughout the body via the capillaries and the tissue cell membranes. And it also acts as a respiration, right? It's the process of gas exchange, removal of CO2, add O2 within the bloodstream with atmospheric air, so the air we breathe. And then ventilation is the other one. So this requires the movement or the thoracic cage wall and the diaphragm, right? And your airflow is dependent on several factors. So there's air pressure variance. So air flows from higher pressure to lower pressure areas. So during inspiration, the air drawn from the trachea and the bronchi into the alveoli, that's with inspiration. And then with expiration, the diaphragm relaxes, the lungs recoil, they go from large to small, and the air flows into the atmosphere. Now, your airway resistance, this is determined by the size of the airways. So any process that changes the size or diameter of the bronchioles alters the rate of airflow and affects airway resistance. And that one thing that you may notice with docs when they're documenting that they have reactive airway disease, or they have bronchiectasis, or they have or asthma, whatever type, you may see that they may be documenting some type of airway resistance within their notes based on those diagnoses. And then compliance is the third part of ventilation. And this is where the elasticity and the expandability of lungs and the thoracic cage, this is where everything moves. Okay. So your lung volumes will increase with pressure changes within the atmosphere and the thoracic cavity, causing air to flow into the lungs. So that's what occurs. Now with functions, this is just a chart that I thought was interesting. It just gives you ideas about contraction of bronchial smooth muscle. That's with asthma. Chronic bronchitis, you may see thickening of the bronchial mucosa. And you may see that even on the x-rays or CT, whatever imaging. So they're trying to see if a patient does have chronic bronchitis or chronic obstructive bronchitis. Obstruction of airway, it could be a tumor, foreign body, or mucus. And then loss of lung elasticity, that's what you usually see within emphysema. Sometimes docs will say emphysema or COPD. They use them interchangeably. We know we have different codes for that in the CDI encoding world. But this is where the connective tissue encircling the airways, keeping them open during inspiration and expiration. So that's why the lung elasticity is gone. It's lost because of that. Okay, so some diagnostic tools to diagnose respiratory diseases. The big thing I think is it's the lung function tests, okay? Usually a lot of the docs, they do this on the outpatient most of the time. However, if they don't know a patient and if they're trying to rule out if they have COPD or if they have asthma or some other lung disease, they may do them in the hospital setting, but usually few and far between are done in the hospital setting. Usually they do them on the outpatient side with the pulmonologist, okay? And this is just showing how well the lungs are working within that patient. So the pulse oximetry, of course, that's easy to get. You know, this is just a probe that is placed on your finger. And we want to see, you know, how much oxygen are you getting? Usually you see it used for your COPD patients. Cystic fibrosis is another one, as well as patients who are on pneumonia, who have diagnosed pneumonia. They're going to do continuous pulse oximetry on those patients most of the time if they're really that sick. Your spirometry is another function type test that measures how much you breathe. This is where you have that the blue ball in the white container, and they want to make sure that everything's working. Your incentive spirometry. All patients after surgery are using that, right? So we want to prevent them from getting pneumonia. And then usually you could read about the test where the technician will tell you how to breathe and how much you inhale and how much you blow out. Some people sometimes will feel lightheaded or tired from the required breathing effort. And this is usually used for patients they're trying to diagnose asthma, COPD, cystic fibrosis, or even your interstitial lung diseases. So you may see that in there, but we know they use them for post-op patients as well. And then the lung volume test. This is a type of lung function test that measures how much air your lungs can hold. So these are the most accurate way to measure the volume of air in your lungs. And it's similar to spirometry, okay? Except that you will be in a small room with clear walls. So they do it in a contained area, a contained environment. And then they ask you to breathe for a few minutes while wearing a clip on your nose. And then sometimes, of course, you can get lightheaded or dizzy or tired. And then they're trying to diagnose, again, your asthma, COPD, or your interstitial lung diseases. And then the lung diffusion capacity test. This test assesses how well oxygen gets into the blood from the air you breathe. So they're going to look at having you breathe in and out of tube for several minutes without having to breathe intensely. And then also they may need to draw blood work to measure the level of hemoglobin in your blood. Again, most of the common diagnoses, respiratory diseases you see, doctors may order this for your COPDs, your cystic fibrosis, and your interstitial lung diseases. Your fractional exhaled nitric oxide, or your FeNO test. This is measuring how much nitric oxide is in your breath. Okay, so if your airways and your lungs are inflamed, it can be hard to breathe. So for this test, you're going to breathe out into a tube that is connected to a portal device. And this is just regular steady breathing, no heavy breathing. And it is done in adults and children age 5 and older. And this is mainly used to diagnose asthma. Okay. Usually I don't see this one done on older adults, your middle-aged or older. It's usually your young adults because they're trying to diagnose if that patient has asthma or not. And of course, our ABGs, we want to measure the oxygen and CO2 levels in the blood. Usually this is taken from the artery, as we all know. And it's, of course, to diagnose COPD, cystic fibrosis, pneumonia, especially COPD patients. It's so painful that you want to make sure that you don't want to keep hurting them, right? Especially your older adults, they want to see what's going on. But if they're ending up on a vent, they're going to throw an A line in them, right? An arterial line, and then they can grab that. They can get that test repeatedly. Now, the next few slides are your ABG analysis. Yeah. Slide needs to advance. Christy, are you there?
Yeah,
You want to go on to ABG analysis?
it is an APG now. It's
No,
not
okay, great.
advancing?
Now, once you click it, it does.
Okay.
Okay.
The
So,
only thing also with that, you know, as a CDI, we rely on the ABG to query whether the patient is an acute respiratory failure. So it is one of the clinical indicators that would indicate to us whether we need to query the physician. So
right. And this is a big piece of the pie when it comes to our respiratory failure, whether it's acute or chronic or acute on chronic. And this, I thought this would be helpful for everybody just to have the ABG analysis. I received this from a nursing book I have, Lippincott, and it gives you information regarding the clinical significance and the normal ranges. I think sometimes you can't find the normal ranges in Epic when you're going through all your lab values. Sometimes they're there, sometimes they're not, depending on how your organization set up the Epic chart, EHR. And then the second slide also goes into your this is all your pH, PaCO2, your bicarb, PaO2, SaO2. And then the next couple slides is a 6-step approach. So this is what they utilize. This is what most of the providers will utilize, a 6-step approach with the ABG analysis. And I thought it gives you some nice, great information, and it explains a little more. So just a little helpful and slides for you as cheat sheets, so to speak. Any questions on that? No, we good?
No.
Okay. All right. All right, let's look at imaging tests. So, of course, chest x-ray is the main one that we're going to look at when it comes to imaging, right? And they're going to look at the structures within the chest, your lungs, your bronchioles, and then, around your chest. We want, of course, usually they can diagnose pneumonia or heart failure, lung cancer, TB, even sarcoidosis, emphysema, and lung tissue scarring, or your fibrosis. So if you see any lung tissue scarring on a chest x-ray for a patient, maybe they're trying to rule out pulmonary fibrosis on that patient. So they're going to do further workup, and usually they start doing a CT on them as well. Now, this test is, of course, can be done outpatient or in the hospital. And you can stand, sit, or lie still for the test, whatever the case may be. Chest x-rays, very few risks, and then talk to your provider if you are or could be pregnant. You want to keep an eye on that for radiation purposes. And then, of course, it's used for all those diagnoses that I mentioned prior. And then of chest CTs, these are really good to get because it gives you further information, pictures or slices of your lungs in different areas. And it's 3-dimensional. So the docs can take a look at the size and shape and position of your lungs and anything, if they see anything else in there. Usually a CT chest is helpful for lung symptoms, right? They're coming in with shortness of breath, or they have chest pain, what's going on. Maybe they catch a tumor on the CT. Now they're going to do further testing, right? And your CT can be done again in a outpatient or a hospital setting. Sometimes they do it with contrast, or sometimes they do it without. It depends on what the chronic conditions patients have. So sometimes you may see them in the hospital. If it's an older adult, they may do it without contrast because of their conditions that they have, or they may be allergic to contrast dye. right? So it depends on exactly what their background is, what their chronic conditions are, their comorbidities. And sometimes you can have a reaction to the contrast dye, so we don't want to put anybody at risk. And used for your COPD, cystic fibrosis, pleural disorders, and your venous thromboembolisms. And then your chest MRI. This is where, of course, we all know about MRIs. Yeah. So this is where most of the time, if they see some type of mass or tumor within your pleura, they're going to do an MRI. They want to see what's going on and check the. No, I'm still on MRI, Christy.
Yeah,
They want to
I
see
put
what.
it back. Mhm.
Okay, thank you. They want to see what's going on, if there's any abnormal lymph nodes, right? Because if they see a mass, they're going to do further testing. They're going to do chest X-ray is going to show, well, there's a shadow. It could be a tumor. And then they're going to do a CT chest, and it's like, yeah, there's a tumor in there. Now we're going to do further specificity of that tumor because we want more information. We want to see if the lymph nodes are involved, if they're enlarged. Is there Mets going on? So they're definitely going to take a look at that. And they usually do it. Most of the time, a chest MRI is done in the hospital setting. Very rarely do I see it done on the outpatient side. Usually they're in the hospital to get an MRI done, for the most part. And, if you have a pacemaker, though, or other implanted device, the MRI machine may damage these, right, devices, especially pacemakers. I know out there today, they have pacemakers that are MRI compatible now, right? The newer ones, so which is a good thing. But any metal you have inside from prior surgeries, it can interfere with the MRI machine. Like if you had a knee replacement or a hip replacement, that can interfere as well. And any metal on your body, like piercings, jewelry, or even transdermal skin patches, can interfere with the MRI machine. It may even cause skin burns, and that could happen. And the other thing they were saying, if you have tattoos, you may feel some itching or swelling because older tattoo inks may contain some small amounts of metal. So again, these are used, this MRI, chest MRI is used for your cystic fibrosis patients, any pleural disorders, like I said, any tumors they may see, and sarcoidosis. Okay. Bronchoscopy. Who doesn't love a bronch? I love my bronchs when I'm seeing that, especially when they capture a piece of the yeah, you're on it, Christy. That's
Huh?
weird. Okay, no worries. Nope, I got it. The
Mm.
bronchoscopy, it's a bronchoscope that's inserted with a light and a small camera. Okay, and they check your lungs. And usually they're trying to see if there's any tumor infection, excessive mucus, right, or bleeding, or even blockages within the lungs. And also, when they're doing a bronch, you always want to see if they took lung tissue, lung sampling out. Because in that respect, from a CDI perspective, you can get instead of a medical DRG assignment, you can get the surgical DRG assignment. So usually they will give you some medicine to help you relax. You may have some sore throat, cough, or hoarseness for a few days afterwards. And usually they're looking for any type of malignancy or sarcoidosis. If you have a history of sarcoidosis, they may see if it has progressed. So they may do the bronch on that patient as well. And pneumonia, if you're not improving with the treatment that's ordered, they may do the bronch to say, okay, what else is going on with this patient? So negative chest x-ray results, sometimes you'll see a negative chest x-ray, meaning they don't see any signs of infection, they ruled out pneumonia, but it could be an early stage pneumonia. So the infection may have not progressed enough to cause visible lung consolidation. Okay. And then x-ray changes can lag behind the clinical symptoms. If a patient is dehydrated, that's a really big piece of the pie. When you see your older adults coming in, it sounds like they have pneumonia based on their clinical picture, and the docs are going to treat them like a pneumonia, and they could be really dehydrated. So your lung opacities may not be clear enough on the x-ray, on the imaging. But then after rehydration, they do a repeat x-ray, and of course they have pneumonia. And also your atypical or viral pneumonias may be negative on chest x-ray. Okay, so you have to look at other causes, like your mycoplasma, chlamydia, or Legionella. Could be an atypical pneumonia. Even your viral pneumonia may be minimal or no changes at all, like our COVID patients, right? When we're going through all that with the COVID pandemic. Okay. Other reasons for negative chest x-rays, your immunosuppressed patients who have HIV or are on chemotherapy or organ transplants because they're on immunosuppressants all for the rest of their lives. They're not easily seen on chest x-ray. Usually your CT scans will give you better imaging and visualization of any problems within the lung. Pneumonia in unusual locations. So it can be missed if it's like behind the heart, it's retrocardiac, or in the lung bases, they're subdiaphragmatic. Sometimes you just can't see them on x-ray. So they may do a lateral x-ray or a CT scan to see behind those other items, the other organs. And of course, if obesity or poor image quality will give you a negative chest x-ray, and obesity can obscure the lung details if you have excessive obesity within the abdominal region. And of course, your CHF. You're going to see CHF on a chest or x-ray before you see any other consolidation or infiltrate to clarify if the patient has pneumonia or not.
Yeah, that's why it's important for the CDI, because sometimes if the patient has congestive heart failure, but actually it's a combination of CHF and pneumonia. So it's a clear opportunity whether was that pneumonia present on admission. So we need to clarify that, because it may change our primary diagnosis and DRG. But like I said, you have to look at the clinical indicators, if it's been treated with antibiotics at the time of admission or not. So it's that's why chest X-ray is important to find out whether that the patient has congestive heart failure. But since the congestion, it is what do you call this, acute. So the pneumonia part cannot be seen on X-ray, but actually, it may be that the patient has both CHF and pneumonia on admission.
Okay. Respiratory system disorders. So let's take a look at some of our conditions here. Pneumonia, of course, is one of the biggest ones that we see in CDI. It could be a simple pneumonia, and they usually call it CAP, or healthcare acquired, right? HCAP. And it occurs in patients who are outside of the healthcare settings, can range from mild to severe. If they're severe, usually the doctors are admitting him to the hospital to give him IV antibiotics. And several factors that can increase your risk of developing CAP. Usually it's age and your medical conditions, right? Lifestyle or habits and your environmental exposures. The organisms that you may see with simple pneumonia, usually it's some type of virus. Your Streptococcus B or other Streptococcus, bacterial, mycoplasma, or even an unspecified. They're not sure what organism it may be, and the doctors will document that. Usually it's affecting your older adults, young children who are with chronic conditions are at the highest risk. That's why you see a lot of older adults coming in with some type of pneumonia. And lifestyle factors, of course, it's smoking is the main one, right? The risk factor is the main risk factor. Even alcohol use and poor nutrition can increase your susceptibility. Any recent viral infections or environmental exposures like pollution, crowded settings play a role in pneumonia risk. Then, of course, your complex pneumonias or your respiratory infections, inflammations. This is more severe, difficult to treat, and you have associated complications like sepsis or respiratory failure. Empyema can develop, as well as any pleural effusions. You can see pleural effusions in simple pneumonia. They may be very trace or minimal or none at all, but your complex, they're going to be, you're going to definitely see them on X-ray, on imaging. And then the reasons why that increase your risk in developing this type of pneumonia is usually your cytomegalovirus, your CMV, or your respiratory TB, pulmonary candidiasis, that's a big one, and your invasive pulmonary aspergillosis, and of course your COVID-19. I've been seeing a lot of respiratory TB coming in lately in the company I'm working for. And I was really surprised. I was like, wow, people are coming in with that. And the company I work for it's an organization in Missouri, and they're in several states within the Midwest. And they've been seeing a lot more TB cases within their area, which is interesting. And aspergillosis, they've had a couple of those cases too, which they usually don't have. These type of complex pneumonias within their area. So the health department is involved in helping them figure out, okay, what's going on? Why are they developing all this? So it'll be interesting to see what develops and what they find out. And of course, your any other organisms like your Klebsiella and Pseudomonas, gram-negative bacteria and Staphylococcus are part of your complex pneumonias. And individuals with weakened immune systems, chronic diseases, or even recent hospitalizations or structural lung disease are definitely at higher risk to develop your complex pneumonias. So it's definitely really prevention strategies of decreasing, identifying, and getting rid of the risk factors that you can, and then aggressive management when pneumonia occurs. So doctors may say the signs and symptoms of abdominal distension, nausea, vomiting, constipation. They're going to do a workup. They're not sure what's causing it. Sometimes they may say, well, they're short of breath, but they could be attributing it to their COPD exacerbation if they have that diagnosis. So the treatment, of course, there's a variety of antibiotics that are used, and I gave you a little snapshot of that at the next one. In a couple more slides. And then some of the code examples you may see. These are pulled right out of the book, the ICD-10 CM Code Book 2025. And then the CDI focus, mainly for pneumonia, you want to specify the organism. What is the causative agent? Organism, what's the bug? You want to document, okay, is it an aspiration pneumonia versus a bacterial pneumonia, or is it a viral pneumonia? You want to clarify if it's a hospital acquired pneumonia or ventilator associated pneumonia is present. And then you want to distinguish between the aspiration pneumonia, if documented, between, is it an aspiration pneumonitis or is it an aspiration pneumonia? Because we have two different codes for those. So just FYI. And then here's the listing of the different community-acquired pneumonia treatments. This was from a medicalletter.org. I found that on. Just a little helpful information. And then, of course, our query sample. You want to add your clinical indicators, and then you want to clarify, does the patient have influenza with pneumonia? And then you want to have them create that link. Most of the time, I am usually sending pneumonia queries. Are you guys sending a lot of pneumonia queries for specificity?
I am.
Are you? Okay.
Yeah, because you'll have one doctor that says, viral, one will say bacteria, one will say aspiration. It's like, okay, so he could have aspirated, and now he might have bacterial, but if he has bacterial and aspiration, does he really have viral? Unless you have a positive viral test. So yeah, I'm still having to send a lot, or get them with cultures to take it to a gram-negative pneumonia, because they're not doing that.
Yeah. So Donna or Patty, you see a lot of those being sent from your background?
We don't usually have the cultures done, but I mean, we do query for the types of pneumonia.
Okay.
The
So
organ.
yeah, I know there are several providers. They will give you pushback if they don't have positive cultures. They won't write that it's a gram negative. Even though they're using the powerful antibiotics like Vanco and Zosyn, right? Your heavy hitters to treat it. But I know there's quite a few providers out there still that will not give you a gram positive or gram negative pneumonia when they're using the big broad spectrum antibiotics.
I think they're afraid to link to it without confirming, but yet they're using, like you said, the heavy drugs just in case that's it, but it's like they're afraid to say it.
Right.
Yeah,
Because they don't have the cultures.
they don't want to commit.
Yeah.
Yep.
That's it. That's true. Okay. All right. All righty. So I mean, I think we all always sending queries for something or another with pneumonia, that's for sure. All right, so let's talk about asthma, COPD, and chronic bronchitis. So your acute bronchitis, it could be acute, chronic, simple chronic, mild, moderate, severe asthma, right? With or without exacerbation, emphysema, other COPD, or bronchiectasis. And the key takeaways with this is your asthma is influenced by both genetic and environmental factors. And children of parents with asthma or allergies are at higher risk, right, as we know. And any exposure to pollution, allergens, smoking, respiratory infections can contribute to asthma development overall. Obesity, stress, and certain medications can also be risk factors associated to the development of asthma or chronic bronchitis. Your COPD is a progressive irreversible lung disease characterized by airflow limitation due to chronic inflammation, airway narrowing, and alveolar damage. So this does include your chronic bronchitis and emphysema, but is primarily caused by your smoking. That's the number one, and all the testing and the research that's been done, smoking is the number one cause of your COPD. There are also environmental exposures out there, as we know, but even a genetic factor. Your alpha-1 antitrypsin deficiency, or I think it's A1AD, is what providers may document within the record if they do have some type of genetic deformity. Okay. And you may see those listed out within the documentation of within the record. So when it comes to our coding considerations for asthma, the docs may document wheezing, dyspnea on exertion, cough, workup. Usually, of course, we're going to get an x-ray. Bedside spirometry may be obtained for expiratory airflow. And of course, your CBC, right, to see if there's any infection going on. Your treatment, nebulizers, albuterol, lavenolin. They'll give IV steroids, maybe IV fluids, and supplemental O2 if their O2 sat is really low. And of course, your incentive spirometry to help open up everything. And then just some of the code examples with your asthma with acute exacerbation or asthmatic bronchitis with status asthmaticus, and then mild persistent asthma with the exacerbation. Now, you know, we have tons of asthma codes currently. I just listed a few of them here. Now, your COPD, your providers may say they have a chronic obstructive asthma. So a patient has asthma and COPD diagnoses. They also may be diagnosed as the patient with chronic bronchitis or even emphysema. Workup is the same as asthma, but they also may do a sputum culture to see if they have anything growing in there. Treatments, IV antibiotics, steroids, and again, albuterol, Ventolin nebulizer treatments. And then code examples, I just put a couple in here. As you know, there's tons of them. COPD with acute lower respiratory infection. If they're diagnosed with pneumonia and they're saying, well, they have a history of COPD and we're going to give them short courses, IV steroids or something, corticosteroids, then you can capture that COPD with acute lower respiratory infection. And then, or COPD with acute exacerbation with the pneumonia, if probably the pneumonia might have triggered that COPD exacerbation. So CDI focus. So what do you want to look at? Asthma type. Your mild, moderate, severe, intermittent, persistent status asthmaticus. Your COPD types, chronic bronchitis, emphysema, or mixed. Sometimes you'll see COPD overlap diagnosis. That's with your, that's like a mixed COPD with asthma. And then it'll code to other COPD within your code set. And then it could be with or without exacerbation or even acute respiratory failure. Oxygen use, long-term O2 or ventilator dependence. So common queries that we're going to send, clarify the type of asthma, if it's status asthmaticus or it's an exacerbation. For COPD, is it a chronic bronchitis or emphysema, or is it overlap COPD with asthma? And did the exacerbation result in acute respiratory failure? You always want to make sure the provider documents the type, severity, exacerbation status, and or respiratory failure presence to ensure proper coding and severity of classification. Because guess what's going to happen? Your severity and your risk of mortality data is going to go higher in your points. And then when it comes, just as just a quick example of asthma COPD query sample, usually the docs are really pretty good for the most part in documenting if they do have an asthma or COPD exacerbation, from what I've seen in my experience and even currently working at the Missouri facilities. So very rarely do I send an asthma or a COPD, which is nice. You know, the light bulb went on, so to speak. Okay. And then our next one is major chest trauma. Now, flail chest can occur with CPR or with trauma, of course. Rib fractures can occur open or closed. Your contusion to bronchi or diaphragm can happen, as well as your anterior posterior subluxation of the sternoclavicular joint. So major trauma is really important, especially when it comes to chest. You want specific diagnoses and injury detailed out. Most of your trauma teams in the facilities are overall pretty good. They're going to let you know rib fractures, the number. If it's multiple, they're going to say multiple. They may not give you the specific, is it, 1 through 3? They'll give you a multiple on the left or right or bilateral versus a flail chest. Any pulmonary contusion or laceration, you definitely want to get the laterality and severity listed out. Your pneumothorax or hemothorax is also important because you want to see if it's specify the presence of it. Is it related to usually MVAs with the airbag when it expels out? You can get major chest trauma, especially if it's a man or a woman who are thin, right? They're not obese, they're thin structure, small structure. They can get injured big time with that airbag. So you definitely want to clarify all that. And then with laterality, and if it's a tension pneumothorax, cardiac injury can be contusions, tamponade, or even a rupture. So you want to make sure the cardiothoracic docs, the trauma docs, are all on the same page with diagnosing and specifying all these injuries out. And also even an aortic injury can occur with major chest trauma. So you want to make sure that, they clarify that. Your tracheal bronchial injuries, what location? Is it the trachea itself? Is it a main stem bronchus? Is there going to need surgical repair if needed? And then, of course, a diaphragmatic rupture can occur too. And you want to make sure that the laterality is documented on those, and if surgical repair was performed. Respiratory complications. Of course, it goes back to your acute respiratory failure. You want to specify the type, whether it's hypoxemic, hypercapnic, or both. ARDS is another one, if applicable. Usually they use the Berlin criteria to support that diagnosis. And sometimes ARDS will develop if the initial injuries are not taken care of, are not treated quickly and fast. A patient can develop ARDS, even if they were treated quickly by the providers, by the trauma team, and they went and they did surgery on them and did everything that they needed to do to help minimize ARDS from developing. The patient can still develop ARDS depending on what their overall health and condition is. Pulmonary edema, definitely you want to check, differentiate between cardiogenic versus non-cardiogenic. And usually it's non-cardiogenic pulmonary edema because if it's trauma related. So you definitely want to send a query on that one. Your surgical or procedural interventions you may see, chest tube placements, of course, a thoracotomy may be completed as well. And of course, your mechanical vent. Most patients who do come in with major chest trauma, especially with a flailed chest, they automatically put them on a vent. I've seen that happen numerous times. And then, of course, your etiology and your associated conditions. You want to clarify what the mechanism of injury is. And usually your trauma docs are really good on that and include any associated conditions. They could go into shock, DIC, etc. Okay. So coding considerations, mechanism is key. Mechanism of injury, you want to make sure that is documented, whether it's blunt trauma, penetrating trauma, is it a gunshot wound, penetrating? Specific injuries with laterality and severity. Interventions performed. 9 times out of 10, you'll see all those documented. Sometimes if they're doing surgery on a patient that came in with major chest, like a severe MVA, motor vehicle crash, or a motorcycle accident, MCAs, it takes a little bit of time for the docs to get those the notes written. So, just give them a little time to get all that documented within the patient's record before you send a query. And then the other one is your complications that developed, and then hemodynamic status. The CDI focus for major chest trauma, your key takeaways. No, you were fine, Christy. Thank you. Your key takeaways. Specify the number and laterality of fractures or injuries. Differentiate simple pneumonia versus tension pneumonia. Clarify presence or ARDS or respiratory failure and its cause. You always want to make sure that your ARDS and acute respiratory failure is linked to what the underlying etiology is, as we all know from CDI. Document interventions that were performed and capture all the associated injuries and complications, shock, tamponade, hemorrhage. And then, of course, your common CDI queries, fracture and injury clarification, or how many rib fractures. I had a couple trauma docs, right? One trauma doc wrote one right rib fracture, multiple left rib fracture. Well, guess what? It was reversed. Then the other trauma doc comes in and says, no, it's one left rib fracture and multiple right rib fractures. So I'm going back and forth with the documentation. And then I look at the chest x-ray and all the imaging, and it's like, no, it's one left and multiple right. So of course, what do? Conflicting documentation. So I got to send a clarification. And then the trauma doctor calls me and says, why are you sending me this? I wrote this. However, if you looked at your prior colleague, he put it the opposite way, doctor. Oh, okay. I understand what you're asking. Okay, I'll clarify it. Thank you very much. So, I mean, little things like that can be very confusing for coders, right? So that's why you want to capture that information. Your pulmonary, any cardiac complications, definitely you want to see what type that pneumonia was, pneumothorax developed from. Any respiratory failure, is it related to pulmonary contusion, or is it related to an underlying condition like pneumonia or COPD exacerbation? Any procedure or intervention queries, why was the chest tube placed? Mechanical ventilation, if they didn't document acute respiratory failure, they're only documenting respiratory failure, but the patient's been on the vent for, 48 to 72 hours. You want to clarify, is it acute? Is it chronic? Or what is it? Acute on chronic? Clarify what it is. Sometimes these patients may be home, maybe on vents at home too. If they have a tracheostomy, that's a big piece of the pie. To find out if they still have a trach in place, they may be vent dependent at home on the outpatient side.
Our docs are so bad on respiratory failure and blood loss. Like it feels like they're afraid it's going to be held against them if they document it.
See, I know, and there's no reason. It is like they're giving their expert opinion on it, right? They're the subject matter expert. They're the MD, right? And they're still afraid. Some docs are just afraid because they think of, unfortunately, lawsuits. They don't want to get sued, and that's unfortunately that's a big part of medicine today. That's why they look at it from that standpoint. So this is just a query sample of major chest trauma. Sometimes you don't need all of these, responses. You create the query based on the clinical evidence in the record, right? And to support whatever diagnosis you may have. Okay. Influenza. So this is a contagious viral respiratory infection, as we know, that are different viruses. They could be A, B, C, D. Though A and B are the most clinically relevant in humans for us. Primarily affects nose, throat, lungs, spreads through respiratory droplets from coughs, sneezes, or contact with contaminated surfaces. Symptoms, it's not just a common cold. Everybody says they may have a common cold, but it comes on suddenly. And people with flu may have the following symptoms. And think facts. Fact with an S. Fever, aches, chills, tiredness, or fatigue. Sudden onset. And then, of course, you have cough, runny or stuffy nose, or a sore throat. Vomiting and diarrhea are more common in children than adults. But if you think of facts as your synonym, and then you can clarify that it may be influenza type. So some coding considerations that we see for influenza. Providers may document influenza with a specified organism like influenza A or H1N1 or coronavirus OC43. That was the big one that came out last year for COVID. It wasn't COVID-19, but it was coronavirus OC43. And they were documenting that. And of course, our workup would be imaging, your X-ray, CT, respiratory PCR panel is always good in the CBC. They'll do treatment antivirals. They may give Tamiflu, remdesivir. They may even give dexamethasone. And then some of your code examples I've listed here. So keep in mind, like I said, these are just a little snippet of all the codes that are available in the ICD-10-CM code book. Then our CDI focus, of course, specify the viral type or other identified strain if it's not listed. Document the complications. If it's a viral pneumonia, they're coming in the door. Do they have a superimposed bacterial pneumonia? Or do they have acute respiratory failure because of the viral pneumonia? and then identify any associated comorbidities like COPD, asthma, or heart failure, and then the severity. Is it uncomplicated versus a severe respiratory distress? And then some of the CDI queries that you send, influenza, viral, or bacterial, superimposed bacterial pneumonia, like I mentioned, and respiratory failure, is acute or chronic? Is it POA status? That's really important to have the POA listed for your accurate coding and reimbursement purposes. And then the next slide is just the query sample that you can pull in. You know, a lot of it, all your facilities have, you all have electronic queries, right? You all have query templates listed that you just pull from.
Yes.
Yeah, for the most part. Okay. Yeah, that's what I would figure. Jeannie, you still work from home, right? Jeannie, you're still working for a contract, you said?
Yeah, I'm with
Contract company?
UASI. Yeah.
Oh,
and
UASI. Okay. Yeah.
Yeah. So, yeah, with them, and I'm at a hospital right now that has the Solventum and Epic.
Oh, okay. Oh, they're using Solventum, huh? Okay. Interesting.
The
How
new
do you
name,
like it?
that's the new name for 3M. It's 3M.
Yeah, I know. Solventum. I know. Yeah. It's the same. They didn't change a lot, though. From my understanding, they were going to add more stuff to 3M, but I don't know if they did or not. So I know
Yeah,
a lot of the.
It seems like they're doing updates frequently, and nothing pertains to me, so I don't even bother to read about what those updates are. But if they ever did, then I would, I suppose.
Yeah, right. I know. I understand that, especially because
A
you're working
lot
on
of updates.
PSI. Sorry?
I said the same with us at Henry Mayo, a lot of updates.
Always. Yeah. There's always doing updates. I think there's constant updates on everything. It doesn't stop. That's for sure. Okay, pneumothorax. All right, this is where your lung collapses, right? Partially or completely, because between the pleural space. And then it could be due to trauma, medical procedures, or underlying lung diseases. So your different types are your spontaneous, that occurs without any underlying disease. And this is usually seen in your young, tall, thin males. Okay. They're in their teenagers, maybe 16 to 20, 25, that they develop it, and they could develop it with a sport that they're playing some type of sports. Your secondary usually is seen with patients who have underlying lung disease, your COPD, cystic fibrosis, or even your ILD or interstitial lung disease, or your pulmonary fibrosis. Traumatic pneumothorax or HEMO, that's relating to blunt or penetrating chest trauma, which we just discussed. Mainly rib fractures, gunshot wounds, or stabbing, or even a post-procedural pneumothorax can develop after they put a central line in. So it'll be listed, I believe, as an iatrogenic pneumothorax in that instance, because it's a complication of care. And then your tension pneumothorax, this is where air enters the pleural space but can't escape, and it's causing increased compression of the lung, heart, and your major blood vessels. And this can lead to life-threatening circulatory collapse. Patients can die with this. So this is a true medical emergency. Your interstitial emphysema, which is a rare lung condition characterized by the accumulation of air in the interstitial tissues of the lungs outside the normal air sacs. So that's a lot of patients who do have some type of emphysema. If they have this, it's really difficult for them to constantly try to catch their breath, unfortunately, with that type of emphysema. And then our CDI focus.
So do we have the coding consideration for pneumothorax?
Oh,
we do
yeah.
that? Oh,
I'm sorry.
mhm.
Yeah. No, I did it. Go back to that.
Okay.
Sorry about that.
Okay.
Okay, Cody, I missed that one. Coding considerations. Providers usually will write spontaneous tension, post-procedural, traumatic, or hemopneumothorax or hydropneumothorax. Of course, your workup is going to be your chest, CT scans, ultrasound they may do as well. Treatment is, small, stable pneumothoraxes usually resolve on its own with oxygen therapy and observation. Any larger or symptomatic pneumothoraxes, they may need to do a chest tube placement, a needle aspiration. Tension pneumothorax, they're definitely going to insert that chest tube ASAP, quickly. And sometimes you see it done in the ER, or the ER doc may do it if the trauma doc is not unavailable. And then any recurrent cases, like if they need pleural desis, whether it's chemical or surgical, to prevent reoccurrence. And you may see that too in your younger adults who develop that pneumothorax, that I've seen that they had to do chemical pleural desis because this 18-year-old young man, every time he was playing his sports, I don't know if it was basketball or softball, he would develop a pneumothorax. Unfortunately, he'd have to be rushed to the hospital. So they ended up doing a chemical pleurodesis on him, where the CT surgeon came in and did it. And hopefully he's doing fine after that. But yeah, so they can develop at any age, recurrent cases. Code examples, of course, your acute and chronic and traumatic and post-procedure or iatrogenic pneumothorax. Especially very thin patients. Yes, absolutely, Jeannie. They're very thin. And these young guys, they can develop them on a regular basis. Christy, you're going to add something?
No, I just want to say, like Jenny said about they're very thin. It's usually like because they're so stretched. So I guess they're prone to that pneumothorax. And I have a friend's son who was diving and also developed that pneumothorax. So
During
fans.
scuba diving?
diving, yeah.
Oh, he's
Diving.
not a candidate to dive anymore.
Right.
Too many problems with that right there.
Right, I know. But Jeannie mentioned Marfan's. Yeah, they may have a diagnosis of Marfan's syndrome.
Yeah.
And I know they work up those young guys for that, especially if they have recurrent pneumothoraxes. So they're doing further testing on them, the young people. Absolutely. CDI focus for pneumothorax, of course, the type, laterality, what's the associated cause? We always want the underlying etiology, and then what the treatment details are, observation versus a chest tube placement, or do they undergo a pleurodesis for those patients? And then some of the CDI queries that usually send, whether traumatic or spontaneous. Most of the docs that I've noted, the providers, with my current contract, they're usually pretty good. They're going to tell you what it is. And was there an intervention performed, chest tube, or are they just monitoring it with serial chest x-rays? And then, of course, any associated condition, COPD, is there a malignancy going on?
And sometimes when I was still working with the case managers at Glendale Benches, they would ask me about, because sometimes they just do it like as an outpatient when they put the chest tube, but then they would the doctor or the billing will put it's an inpatient. So sometimes it becomes a problem. So the case managers will what do you call this, confer with me whether it's an inpatient and outpatient, because sometimes putting the chest tube, I think they have that the chest tube that is the patient can go home with it. It's portable. So that's when I have an interaction with the case managers to find out whether it needs to be an observation outpatient or is it an inpatient. So
Pigtail chest tubes. That's
yeah,
what it is.
that's what it is. Yeah.
Thank you, Jeannie. Yeah. And that's what you'll see. Sometimes patients, they try to remove the chest tube, right? They don't want patients being discharged home with them unless they absolutely need it. But it's really important to keep an eye on that. And case management too usually get involved with length of stay, right? They're in charge of the
Yeah.
length of stay for the most part for medical necessity. So we help them too from a DRG perspective, right? When we're reviewing the record and we're assigning our MSDRG, does it meet the length of stay that we have that's listed in there and the GMLOS of the DRG assignment? So we work with case management regularly, like nutritionists. And then this is just a sample query for your pneumothorax.
It was
Okay.
interesting. I had a patient recently that had a clear chest x-ray prior to coming in for an outpatient bronch because they saw some lesions on the left side of the lungs. Did the bronch on the left side, did the post-procedure chest x-ray, and had a right pneumo. And he
Oh,
was
wow.
nowhere near the right side.
There you
Hmm.
go. See? And that can happen. I mean, you know, unfortunately,
No, he was stunned. He's like, I was nowhere, you know, the way he documented it, he was flabbergasted because he was nowhere near where that occurred. It was interesting.
Yeah.
and yeah, I believe that. That's for sure. Okay. Respiratory neoplasms. Fortunately, we see more and more of this, lung cancers, whether it's benign or malignant. And it can be in any part of the respiratory tract, right? The lungs, bronchi, trachea, pleural, or even overlapping sites, heart, mediastinum, pleural, and even your intrathoracic organs. Okay, your malignant is the most aggressive, right, and can metastasize to other parts. You can have primary lung cancer, which is originating in the lung, and it could be non-small cell lung cancer. And this is about 85% of the cases. And it could, or, you know, and usually the hemoncs are good in diagnosing whether it's adenocarcinoma, squamous cell, or large cell. And then you also have small cell lung cancer. And this is about 15% of the cases. This is the most aggressive type of lung cancer. So if patients are diagnosed with small cell lung cancer, unfortunately, usually the providers are asking for hospice services at that point. Other malignant tumors you may see is the mesothelioma, which affects your pleura. And usually it's linked to asbestos exposure. Your carcinoid tumors are slow growing and rare. And then you can have tracheal or bronchial carcinoma. Then, of course, your metastatic lung cancer, your primary site could be from breast, colon, or kidney cancer, and then it mets to the lung tissue. Benign or your non-cancerous neoplasms, usually your pulmonary hematoma, also known as benign lung tumor. The docs usually will write benign lung tumor. Papillomas, chondromas, or your fibromas. And treatment, surgical removal, of course, chemoradiation. Any targeted therapy too, they may, depending on how severe it is. If it's a small cell lung cancer, the SCLC, they may do targeted therapy with an inhibitor. I can't talk anymore. With the EGFR or the ALK inhibitors. Excuse me. Thank you. And then even immunotherapy and even palliative care, like I said, or hospice services may be assigned. Okay.
You're kind of choppy.
Yeah.
Mhm.
So, coding considerations. This is, like I said, I got it right from the book, the ICD-10-CM 2025 code book. Provider terms you may see: primary small cell lung cancer with mets to spine or liver, prostate cancer unknown primary or secondary, secondary colon cancer unknown primary site, history of ovarian cancer, status post hysterectomy. And then, of course, your diagnostic workup would be x-rays, CT scans, and then your cancer testing, your CEA or CA 19-9. Treatment based on what they find out, what type of cancer. It could be chemoradiation. It could be just radiation. It could be just IV chemo, or it could be oral chemo agents. And then this is just a code example I gave you. This is capillaries, carcinoid, and the different cardiac It says cardia, which is your gastric or your cardiac orifice, cardio-esophageal junction. And then there's a couple of the cartilage on the bottom. And up on top, it gives you whether it's, I'm sorry, can you go back, Christy? It gives
Where?
you whether it's primary, secondary, is it benign? Okay, so it specifies out, or if it's unspecified behavior. So the code book is really good to have as a, it gives you an idea. And that way, when you're trying to code the neoplasms, it's nice to have a little ICD-10-CM code book with the neoplasms because it'll give you everything, which is nice. Okay, thank you.
Is something wrong with your microphone? It's kind of choppy.
Is it choppy?
Oh, it's better now.
Is it better? Okay.
Yeah. Mm-hmm.
All right. So our CDI focus, key points, type and histology, your staging. Of course, we know the TNM classification. Location, where is it? Is it upper, middle, lower? Is it central versus peripheral? Your metastasis, is it brain, liver, bones, contralateral lung? And then treatment, surgery, chemo, radiation, targeted therapy. And any complications that may occur, post-obstructive pneumonia, hemoptysis, or even a malignant pleural effusion can develop for this, which would be listed as a secondary diagnosis. And then, of course, some of the CDI queries, the exact histological type of tumor, clinical staging, any documented METs, specify whether the documented lung mass represents primary or is it secondary or is it a benign tumor, and then where is the neoplasm located. Laterality is really important. And then, of course, your chemotherapy. And most of the docs, yeah, Jeannie.
Yeah, I just thought I'd mention, I kind of stumbled across it a while ago that, most of your oncology patients probably have an implanted port, and that implanted port has a code, the presence of a implanted vascular device, portacath, and it counts for Elixhauser, Vizient, and an HCC. So as long as it meets the criteria for a secondary diagnosis, the nurse is doing an assessment on it, somebody mentions, oh, the chest, oh, there's a port and the skin is clean, dry, whatever, then you can code that.
Oh, interesting.
Great.
Mm-hmm.
Thanks for sharing that. Because I know there was something that was updated with the ports, with the portacaths.
Has a code for it.
I'm sorry, Debbie, what did you say?
I say, yeah, it has a code for it because I've been able to code those lately when they've come in.
Mm-hmm.
So it's a nice capture.
It is.
I think that's really important.
Our coding department, at first, they didn't want to take it. And so I was querying my doc to say, hey, is this clinic, I see this on the x-ray, is there a port? And so, but now I've learned just look for the nursing documentation almost every time. It's going to be under the, IV assessment, because they've probably accessed it. Even if they don't access it, as long as somebody has noted that they've done an assessment of the skin over the area, our coders will take it.
There you go. Good to know. Well, thanks for sharing that. That's great. And everything that we can get to clarify anything, especially ports, things like that. Z958.
Yeah. Oh yeah, I gave you the code. The ED docs are documenting it a lot, which is nice.
Yeah, the ED docs. Yeah, that's always helpful. So, all right, excellent. Thank you for sharing that information. It's all about sharing in CDI, that's for sure. And then here's our query sample for respiratory malignancy.
So yeah, you could just personalize, whatever, you need. It's just a sample.
Right.
Sharing that because that's a good sample.
Okay. You have another question, Jeannie, or you're good?
Sorry, I probably just forgot to put my hand down.
Okay. No, I'm just double checking, make sure we're all good here.
I'm
All right.
planning ahead. It's for the next question. I'll get there again.
There you go.
Queen's wave down.
All right. Pulmonary embolisms, PE. We all know this is definitely life-threatening, and it usually is derived from a DVT that travels to the lung, causing obstruction of pulmonary arteries. Embolism within the pulmonary vascular usually occurs from venous embolism, as we know. So we want to look at the type of PE, whether it's acute versus chronic, a saddle PE, which is very life-threatening, and if they have a recurrent PE. Your etiology and risk factors usually provoked means that it was caused from another etiology, like surgery, trauma, or a cancer. Unprovoked, no clear risk factor, no clear reason why it developed. Cancer associated, which is Trousseau's syndrome. So you may see Trousseau's syndrome documented by the providers if the patient has cancer and they're treating it and they develop Trousseau's syndrome, which is a PE for that patient. COVID-19 related PE. And then any complications and severity. Is there a right heart strain or failure? That's where your acute cor pulmonale comes into place. Most of the times, unfortunately, when I've seen saddle PEs, usually they have acute cor pulmonale going on, and they have hemodynamic instability. They do develop shock with pulmonary infarct and respiratory failure. And it could be, they could even develop sepsis because of the PE. Diagnostic confirmation is, of course, your CT pulmonary angio, your VQ scan, D-dimers, and your lower extremity DVTs are your, venous Dopplers. Treatment, anticoagulation. They may even do thrombolysis or TPA if it's severe enough with a massive PE or your saddle PE. Surgical or catheter-based thrombectomies will occur. That's where your interventional radiology comes into play, where they do that. And also your vascular surgeons may do thrombolysis, where they're going to insert the catheters and they're going to keep them on the IV anticoagulation for 24 hours to see if it opens up that clot and helps dissolve it. And then they'll bring them back to the OR the next day to see if it has resolved or not, or did they develop more. So that's when they do a lot more further treatments, and they may even do a thrombectomy if the thrombolysis did work and it's starting to take away the clot. They may keep the thrombolysis going for another 24 hours, and then interventional radiology may get involved too the next day to take away the rest of the PE, the embolism that's there. And also they may even put an IVC filter in them as well. Coding considerations, the provider will say saddle pulmonary embolism or pulmonary embolism infarction, a septic pulmonary emboli or a subsegmental PE, or a chronic PE. Your diagnostic workups could be chest x-ray, ECGs, troponins, BNP, a CTA of chest or VQ scan, D-dimer, and then your ultrasound venous duplex. Treatment, usually heparin drip. They may use they may even use TPA, and they're going to be on long-term anticoagulation. If it's possibly recurrent, they may be on long-term anticoagulation. Your thrombectomy and embolectomy procedures may be performed. And then these are just some of the code examples. Fat embolism of pulmonary artery without acute cor pulmonary, or another fat embolism. And these are some new codes. So you want to keep an eye on what type of embolisms may be out there besides pulmonary. Okay. Yes, Debbie.
Recently, I had done some investigation and as far as the DVT and PEs regarding being, like after discharge, but they come back in and the doctor's documenting acute of both or depending what they have, one or the other. And that if it was within the 30 days, it was still considered acute. And then I had heard that that was changing. Does anybody know if that changed?
I haven't seen any updates on that yet. I think they may be, if they did change it, maybe it was in the April release from CMS, but I haven't reviewed anything recently, so
Okay,
couldn't tell you.
thanks.
But if I do find anything, I'll take a look at CMS's website to see if they did update that.
Okay.
Okay. Let me just make a note here. Okay.
I had to
All
go
right.
to the coder on that, so I just want to make sure I'm current.
Yeah, right. Jeez, yeah, I'll take a look at it for you. I'll get back to you on that. I'll get back to everybody on that and just let everybody know. So our CDI focus, of course, the type, what's the extent? Is it massive? Are they hemodynamically unstable? Is it subsegmental? And now coders, from a coding perspective, the coders can pick up the subsegmental or segmental from the imaging results now, instead of clarifying and querying the doctor with all this little stuff. So usually they'll list the chest x-ray, the imaging results in their notes, in their progress notes. But the coders can pick up all this information from the imaging as well, which is nice. Your right heart strain is really important. Did they check it by echo, or is there a BNP elevation? What's the underlying cause? Was it provoked or unprovoked? If it's unprovoked, usually they have a hemonc come in, or a hematologist come in to check your hypocoagulability levels, your panel, to see what's going on. Do they have some type of blood dyscrasia that that patient developed that PE? Complications, was there a pulmonary infarct or acute cor pulmonale associated with it? And then, of course, your treatment is usually your anticoagulation, thrombectomy, and or thrombolysis for massive PE. And then your clarification types would be type, severity, cause, and then whatever treatment, if they're not documenting it. For the most part, the docs are really good with, documenting their me criteria, so to speak, right? When they're diagnosing everything. And then, of course, our query sample. Now, of course, you wouldn't put all this in. You conform it to what your clinical indicators are. Respiratory failure. What we all know and love, respiratory failure diagnosis. What type is it? Is it acute, chronic, or acute on chronic, with the specificity of hypercapnic, hypoxic, or both? Etiology, what's the underlying cause or the trigger? It could be pneumonia, pulmonary causes, pneumonia, COPD, asthma. Maybe they have ARDS or a PE, right? Could be a PE or pulmonary edema, whether it's cardiogenic versus non-cardiogenic. And then, of course, your non-pulmonary causes, neuromuscular disorders. That's your myasthenia gravis, Guillain-Barré syndrome, a drug overdose. You will more than likely see acute respiratory failure with any drug overdoses if it's severe enough. Sepsis, of course, we may see it, as well as heart failure and trauma. And then your respiratory treatments, usually your invasive mechanical vents. They can use non-invasive, your CPAP or BiPAP, high flow nasal cannula, any oxygen therapy, whether it's low or high concentration. And then for severe cases is your ECMO. Usually the community hospitals, I work at a hospital, I'm in a trauma hospital for my contract. And they do ECMO cases. They do really a high end of a lot of trauma patients they see on a regular basis in Missouri. It's unfortunate. And some of these people are very young. So some of the coding considerations. So what are the provider terms? You may see acute hypoxemic respiratory failure, acute on chronic hypoxemic, or just plain hypoxic respiratory failure, right? You may have to clarify the acuity. acute hypercapnic, acute on chronic hypercapnic, and etc. Diagnostic workup, usually ABGs. Sometimes you'll see venous blood gases being drawn before ABGs are drawn. If they're on a vent, they're going to put, like I said, an art line in them. And so they can draw the ABGs to make sure that they're not over oxygenating them, the patients, and cause more problems. And then, of course, your CT, chest, and x-rays. Treatment, O2, BiPAP, mechanical vent. I hate VBGs. Yeah, I know. I agree. They're a pain in the butt, in my opinion. It's easier with ABGs, that's for sure. Maybe the patient's on home oxygen for COPD, so they have chronic respiratory failure. But are they using, did they increase that baseline supplemental O2 to have an acute on chronic respiratory failure? Are they given IV salumedrol or bronchodilators, nebulizer treatments for the most part? You will see that. And also some of the code examples listed here. Okay. CDI focus, our key takeaways, of course, type, clarify it's hypoxia or hypercapnic or both. What's the underlying etiology or cause? Capture the treatment details, specify any complications and associated conditions, and avoid common documentation pitfalls, like avoid terms like hypoxia or respiratory distress. Are they in acute respiratory failure? If they meet the criteria, you know, does the clinical evidence in the record support that diagnosis? Do not document impending respiratory failure. Clarify, does it meet failure criteria? And I know there's some coding guidelines out there for impending respiratory failure, and I know Pinson and Tague has it listed in there as well. So you definitely want to clarify, especially impending respiratory failure, and then the next minute they're on a vent. Yeah, we got some respiratory failure going on, I think, acute. Ensure accurate cause and effect relationships. What is the acute respiratory failure due to? And then you want to differentiate, is it a post-op respiratory failure from expected post-op respiratory support? Ensure duration and interventions. Now, usually for prolonged intubation, it's greater than 48 hours are documented, okay? So if they're still on the vent and 72 hours after procedure, find out what's going on. Is it truly a post-op respiratory failure diagnosis and it's related to the surgery? Or is it related to an underlying etiology? And that's something that you definitely want to clarify, because you don't want the surgeons getting dinged with that post-op respiratory failure diagnosis. And then, of course, any atelectasis, if it's documented, or is it clinically significant? You know, do they need a bronch? Are they doing a bronch at the bedside when they're vented to see what's going on with this atelectasis? So those are some of the things you want to keep an eye on. And then, of course, our query sample for respiratory failure. And then, like I said, you would just, you know, customize it to what you have within the clinical indicators in the record. And this, we just gave you a little, just some bullet points on what clinical indicators you can use from the record. And I think it's really important to clarify all that. Okay. Acute respiratory distress syndrome. So it's a non-cardiogenic pulmonary edema where the alveolar capillary membrane is damaged and fluid leaks into the interstitial space and alveoli. Causes usually occurs due to sudden catastrophic conditions such as near drowning, sepsis, multiple trauma, hypoperfusion, a drug overdose, and or hemorrhagic shock. So those are the main causes for ARDS. You will see that listed. Some of the coding considerations, the providers may say ARDS, acute respiratory distress syndrome, acute respiratory failure leading to ARDS, and ALI, acute lung injury. Diagnostic workup, of course, they're going to do ABGs on these patients. And usually they're on a vent for the most part because they just can't breathe on their own. And the PF ratio is usually under 300, and they're going to do chest x-rays. They may even do CT scans, CT chest, like we said, if it's a trauma, major trauma injury. And treatment, again, mechanical vent, ICU status. They're always in ICU for these patients. And then treatment of underlying cause. Just the code examples that I put here. The acute respiratory distress syndrome is a J80. And then your acute lung injury is your S27.309. And then key documentation, of course, you want to confirm ARDS diagnosis using Berlin criteria. And this gives you a little snapshot of what the Berlin criteria is. What is the underlying cause? Is it infectious versus non-infectious? Clarify management and severity. How much oxygen are they on? Are they on a vent? Do they put them on ECMO? Are they doing prone positioning? Are they doing neuromuscular blockades? With meds, so you got to keep an eye on that. And then, of course, POA status is really important. Are they coming in the door with that, with ARDS, or do they develop it in the hospital setting due to what brought them to the hospital, like an acute trauma? And then this is just a query sample. All our per COVID patients, yeah, unfortunately, they go into ARDS, Debbie, you're right, especially the older adults, because they just don't have the fight within their body to prevent it. And then you want to look at, is it ARDS? Is it mild, moderate, or severe? Or is it just acute hypoxic respiratory failure without ARDS? Definitely want to input your clinical indicators on these patients. All right, pulmonary fibrosis. So, also known as interstitial lung disease, or ILD. This is a restrictive lung disease where the alveoli are unable to fully inflate due to fibrotic tissue. You want to specify the type of pulmonary fibrosis. Sometimes patients, doctors do not know what type. It could be idiopathic pulmonary fibrosis, IFP, which is the most common form because they don't know how it was caused. They're not sure if they were, it was an environmental or occupational exposure related. So is it asbestosis or a silicosis? Is it a post-inflammatory fibrosis? Is it due to ARDS or COVID-19? And unfortunately, COVID-19 patients, they will develop that if they have any type of lung history, underlying history. You want to identify if it's primary versus secondary, if they know what the cause is. Clearly stated fibrosis is due to meds. And sometimes I've seen where they have fibrosis due to amiodarone or methotrexate, your RA meds or your cardiac antiarrhythmic meds, even radiation therapy would be listed too by some providers. And then the severity and functional impact. Is it a progressive worsening or is it stable? Is there any associated respiratory failure going on with this patient? And is there some oxygen that's needed, or do they need pulmonary rehab down the road? If they come in with pulmonary fibrosis with an exacerbation. And then some of the coding considerations, doctors will write ILD or lung fibrosis or diffuse parenchymal lung disease. You may see that listed. And then, of course, your diagnostic testing, your x-rays, CT scans, and they do high resolution CT scanning to pinpoint exactly where the fibrosis is so they can take a look at the whole picture, all the lungs in that three-dimensional way. Your spirometry, exercise test, ABG, of course, and even a bronch may be performed for these patients. Treatment, some of these are the new meds that these were shown in clinical trials to slow down the rate of fibrosis or scarring in the lungs. So I believe they are approved now by the FDA. So that's why these are listed in here now. And steroids, of course, excluding steroids are given if they don't have the IPF, okay, the idiopathic pulmonary fibrosis. They may not give any steroids because they don't know what the cause is. And doctors are going to see, okay, what else is going on with this patient? They want to try to get the underlying cause for that IPF. And then just some of the code examples that are listed here. Okay, and our focus, key documentation, again, your type of pulmonary fibrosis. Is it an acute exacerbation or is it chronic stable disease? Assess respiratory failure. Is there acute chronic or acute on chronic respiratory failure happening for these patients? What are some of the complications or comorbidities associated? Do they have pulmonary hypertension? Is there some core pulmonale going on or a right heart failure? Any oxygen dependence, ventilatory support needs? Most of these patients who do have pulmonary fibrosis, once it progresses, they are on oxygen 24/7, unfortunately, and it gets worse as an end result, as we've seen that with end-stage disease. And then even sometimes they will need a lung transplant down the road. Maybe they already had one. Okay, so you want to make sure you clarify if there is a Z code for this patient, because that would be a CC capture and increase your mortality and severity indexes. Common queries, the type, severity, and progression, any underlying etiology, the cause, if there is an acute decompensation. And if an infection or heart failure is ruled out, but the patient worsens, document acute exacerbation of pulmonary fibrosis for correct coding. So you want to clarify if there is, if they ruled out all other underlying causes and there's an acute worsening, then more than likely their pulmonary fibrosis has progressed and is worsening. So there's an exacerbation going on. And there is a code for that. Okay. And then this is just a query sample. Now we say, place your clinical indicators, and then of course you customize it for what you want to clarify for that patient. How you all doing? You good?
Can we have a pee break real quick?
I was going to say, you want to take a little break before we get into the tracheostomy complications? Okay. Yeah. How about it's 11 o'clock, so let's take 10 minutes.
Okay.
Sounds good.
Okie doke.
Better.
Krista, you there? Christy? Oh, she's muted.
Can you hear me?
Yeah, now I can. I was like, where is she? Is she there? I don't know if she's there or not. Yeah, now I can. So did Lorna ever get back to us or no? Can you hear me?
I hear you.
Debbie, you hear me? Okay. Patty and Donna, are you guys back? Yeah. Okay, great. Thank you. Is Jeannie back?
I'm here. I
Okey-dokey.
collected a couple of chicken eggs, and then I'm all out of things to do in my backyard. So yeah, I'm here.
There you go. There you have it. Okay. Christy, can you go to the slide 71, tracheostomy complications first, please? I don't know if you're talking or not. Oh. Hey, there you are. You want to go to the prior slide for me, please? Okay, thank you. All right, let's talk about tracheostomy complications. So early complications, this is considered acute. It's less than 7 days post-procedure. You may have some bleeding or hemorrhage due to a vessel injury during or after the procedure. A pneumothorax can develop. You also may have some subcutaneous emphysema, where the air is trapped around the skin around the trach itself, the stoma. You could develop an infection. It could be localized or systemic. It could be tracheitis or wound infection. And then dislodgement or accidental decannulation. It's premature removal leading to airway compromise. And then some late or chronic complications. These are greater than 7 days post-procedure. Tracheal malacia can develop, which is the softening and collapse of the tracheal wall due to prolonged pressure. Tracheal stenosis can develop, which is a narrowing of the airway itself that leads to respiratory distress. Any granuloma formation, this is overgrowth of tissue at the tracheostomy site causing obstruction. Your tracheal esophageal fistula, which is an abnormal connection between the trachea and the esophagus. Aspiration pneumonia, of course, due to secretion of aspiration or dysphagia, and then failure to wean. They're on prolonged tracheostomy dependence, and usually these patients who are on a trach or who are trach dependent, 9 times out of 10 are on some type of mechanical vent at home, a little ventilator. Okay. Some coding considerations. Provider terms, you may see the docs write tracheal stenosis or tracheal malacia, tracheal hemorrhage or tracheostomy infection, or even dislodgement of the tracheal tube. It should be tube, not tub. Then we're missing an E. Diagnostic workups, of course, your chest x-ray, CBC, CAT scans. Sometimes with treatment, they may even do a bronch or revise the tracheostomy stoma itself. Of course, they're going to give some sedation, and they have specialty dressings for the tracheostomy care. So some code examples: a mechanical complication of the tracheostomy, you may see listed as J9503, hemorrhage or infection of the trach, or other specified tracheostomy complication, if you do not have a code for a specific tracheostomy complication that's listed by the provider. The key documentation points we look at: what type of complication is it? Is it infection, mechanical, or is there bleeding, or is there a fistula formation? Timing, early or late, intervention required, tube change, debridement, or bronchoscopy, any other procedure that's performed. And then your common CDI queries: what type of complication is it? Sometimes the docs are good if they're, they have a long-term trach, and they're vent dependent on that trach, with that trach. They'll tell you what's going on with that patient. Was there emergent intervention needed? You want to differentiate between early or late complications and associated conditions. And then specify if the complication was pre-OA or hospital acquired. 9 times out of 10, if they're coming in with a trach and they're ventilator dependent, you're going to have a POA complication code as your PDX. And then your CDI focus, just a query example, has developed increasing respiratory distress. Provider documents trach issue without further specificity. So you want to really clarify what the problem is. And then this is just another sample for tracheostomy complications. Of course, you customize it based on what your clinical evidence is in the record. Okay. Pulmonary edema, what we all know and love. We know it's fluid buildup in the lungs. The symptoms usually dyspnea, orthopnea, pink frothy sputum, or tachypnea. Signs that you may see in the physical exam: findings, crackles, JVD, distension of the jugular veins, S3 gallop, peripheral edema may also occur. We need to really differentiate: is it cardiogenic or non? With cardiogenic, usually they have some type of cardiac disease, right? Or valvular disease, heart failure, or an MI. They have a high BNP. If they have a wedge in a PA catheter in place, the wedge is going to be higher. Usually they're in ICU for that. And then of course your X-ray would show cardiomegaly or pulmonary venous congestion. Your non-cardiac, usually it's associated with another cause, right? Your sepsis or ARDS, aspiration, high altitude edema. You have a normal BNP, and your X-ray shows sometimes diffuse infiltrates, but your heart size is normal. And then a sample query for this one would be, or coding considerations. Providers would indicate lung congestion, lung water, pulmonary congestion, or heart failure. Sometimes that's a big piece of the pie too. And I'm always clarifying: is it really a true heart failure, or is it just a non-cardiogenic pulmonary edema? And I see the docs writing heart failure all the time, and they're giving that patient a diagnosis which they never had. So now they're putting them in another bucket, right, for CMS bucket with HCCs and everything else. So you definitely want to clarify if is it a true heart failure that's causing the cardiogenic pulmonary edema or not. Definitely clarify that. You don't want to give them a diagnosis they don't have. Chest x-rays are done. Your pro BNPs or BNP, your ABGs, I'm sorry, can you go back up? And then, of course, your treatment, if it's cardiogenic pulmonary edema, it's going to be your Lasix, morphine. And they may give you some nitrates and, of course, any oxygen. And then usually upright positioning. And your non-cardiogenic, you're going to treat the underlying cause, whether it's infection, trauma. They'll do lung protection, ventilation. They'll put them on low tidal volumes on the vents. And they do conservative fluid management and ECMO in severe cases. And then just some code examples listed on the bottom. And then our CDI focus for pulmonary edema. This is just giving you a little snapshot. I picked this up through CMS website, and it tells you, you know, what truly is a cardiogenic pulmonary edema versus non-cardiogenic pulmonary edema, like ARDS. Okay, this is what you would look for in the record. And then the other CDI focus we have in here. Just key documentation points. Again, clarify if it's cardiogenic versus non. Look at all your diagnostic workup, your BNP, echo findings, chest x-ray, and then what type of management treatment are they given? Are they doing diuretics, vasodilators? Are they diuresing, CPAP, BiPAP? And then clarify cardiogenic versus non, and then associated conditions. I really think it's important that you do clarify all that because you don't want to give a patient a diagnosis that they really don't have. I had one patient, I had to send a clarification for pulmonary edema on a patient just at my prior organization I worked for as a contractor. And the doctor, the cardiologist says, I said there's no heart failure on this patient. Patient does not have a diagnosis, but the hospitalist kept writing it. So I sent it to the hospitalist, and the hospitalist turned it to the cardiologist on the case. And the cardiologist ended up calling me. I was like, you know what? Maybe you should talk to the hospitalist because he keeps writing that the patient has heart failure. You know, diastolic heart failure, acute diastolic. He goes, no, this patient does not have heart failure. It's non-cardiogenic. I said, can you please talk to the hospitalist on this case? I'd appreciate it, Doc. And he did. So finally, the hospitalist updated all his notes. I got rid of it. So, because the coder did code it. And the patient wasn't even discharged on any diuretics or anything. There was no treatment for the heart failure on the outpatient side.
Especially if you have any kind of kidney disease, sometimes that BNP is not accurate too.
Correct. So you really got to take a look at the whole picture, right? Your whole case scenario. The doctors get upset with me, but they call me, you know, it's like, okay, let me talk to you. I'll be happy to talk to you. You know, give me a call. So I'd rather clarify it with them to understand why the query is being sent, you know.
Definitely.
Yeah. Okay. Okay, Christy, are you there? I don't know. Are you guys, Christy stopped sharing her screen. Do you guys still see it or no?
Nope, not seeing the slides.
Yeah, no slides, just our names in the circles.
Okay. I wonder what happened. Oh, she's having, hold on. Oh, her battery went down. Okay, well, let me see if I can, if I can share here. Hopefully. Let's see if you guys see it.
It's trying. There it is.
You see it?
Yep. The main first slide is what I see.
Okay. Do you see this one?
Yes. CDI
Okay.
focus pneumonia.
I'm just not going to put it on a slideshow presentation then. Maybe it doesn't work with the Zoho. I think we were on tracheostomy, right? Okay. Yeah, here we go. Okay, everybody's going to see the slideshow. That's all. Okay. And I know we went through this
We're on
one,
pulmonary
edema, right? Okay. So we were talking about that. Coding considerations, again, like I said, you definitely want to keep an eye on that. I thought this was a nice little chart, like a little helpful hint cheat sheet for us, you know, for the CDI staff, just to give you a little more information. And definitely, like I said, you always want to clarify, is it cardiogenic versus non? And then our query sample. Of course, you customize it based on what the clinical indicators are, your clinical evidence in the record. Any questions on pulmonary edema? We good? Okay. All right. Let's go into obesity hypoventilation syndrome, OHS. This is a respiratory disorder for patients diagnosed with obesity. When they have morbid obesity, I'm talking, you know, usually 50, their BMI is 50 or above, and they have some type of COPD or lung disease. Most of the patients are diagnosed with OHS, okay? And they have obstructive sleep apnea. You want to see if you can get that link for OHS, the obesity hypoventilation syndrome. Usually the 3 criteria that has to be met includes their obesity. Now it says BMI greater than 30. Now it depends. There could be other literature out there, but this is what I found within the pulmonary journal that I researched. So they had that. They also have daytime hypercapnia. So their PCO2 is greater than 45. Okay. And exclusion of other causes of hypoventilation. So you want to make sure they don't have severe COPD or chest wall deformities or any neuromuscular disease, because then they may not necessarily have OHS. Okay. But note, 90% of OHS patients have concurrent obstructive sleep apnea, but 10% may have isolated OHS without obstructive sleep apnea. So it's rare to have, it's rare if you have just OHS, obesity hypoventilation syndrome, separate from obesity or obstructive sleep apnea. So just keep a little mental note of that. And then the key takeaways for OHS, again, the 3 diagnosis, 3 criteria has to be present in order to really go forward with an OHS diagnosis. 90% of your OHS cases are linked to OSA, and usually the sleep study is the one that confirms that obstructive sleep apnea. BiPAP is first line for severe cases and CPAP for milder forms. Weight loss is key to long-term resolution. And then we want to document the severity, OSA association, and respiratory failure type for CDI accuracy if there is any respiratory failure going on. Sometimes these patients may come in with acute respiratory failure and the doc's not sure what's happening because they ruled out pneumonia or ARDS or other problems or even COPD exacerbation, but they're not sure what's happening, but they're looking at their obesity level, and then they're going to call Pullman and they're going to decide that it could be OHS for these patients. And just a little BMI classification. These are the WHO and CDC guidelines, where your severe morbid obesity is obesity class 3. Some of the coding considerations, the providers will write OHS or Pickwickian syndrome. It codes to the same, the E66.2 for coding purposes. Your workups, usually your ABGs, and with a high BMI, greater than 30. Most of the time, like I said, I've seen patients with OHS, they have a BMI of 50 or higher. Treatment, usually a nutritionist will be consulted. They'll do an exercise program, medications, possibly even bariatric surgeries. So our key points distinguish between obstructive sleep apnea. Is it just obstructive sleep apnea or is it OHS? Okay. Is there chronic hypercapnia going on? Are these patients on home O2? Are they dependent on home O2, continuous oxygen use? Is it for another condition though? Okay. Or is it for OSA? Okay. Is there, or they have chronic respiratory failure because of COPD. So you really got to take a look at the whole picture and what their treatment is. CPAP, BiPAP, weight loss, of course, intervention, and then clarify obesity severity. Some of the common CDI queries, whether type of respiratory failure, of course, with the acuity, acute or chronic. Is it obesity related hyperventilation? Is it associated with the OSA? And I've sent a couple of those, and the docs were really good in explaining that it wasn't, and they give me a more specific diagnosis associated with the OSA. And I thought that was very helpful in that respect. Does the patient require any non-invasive ventilation? Okay, CPAP or BiPAP. And then the key takeaways, OHS, everything that we just reviewed is just giving you a summary. And I think this is just one that, obesity hypoventilation, is OHS ruled in or ruled out? Is OHS present? Is there further specificity? Is there some acute on chronic respiratory failure? Now, if they're on home O2, right, it's got to be above, higher than what their baseline O2 is used. So just keep that in mind. If they're on the same amount of O2, you may not want to ask for, respiratory failure or just chronic hypercapnic respiratory failure. Okay, so you always want to modify your query templates to what the clinical evidence is in the record. All right. Lung transplantation, rejection, or failure. Do you guys deal with lung transplants?
No.
With surgeries or no?
No.
Surgeries, no, but sometimes get them coming in with issues because their transplant there is rejected or failed.
Okay, so they had it already, so you may see these patients then. Okay, all right. So these definitely, the patients that usually have a lung transplant, they have end-stage lung disease, like your idiopathic pulmonary fibrosis, end-stage COPD, or even your cystic fibrosis patients, usually those younger people, the young adults may go through a lung transplant in their 20s or 30s. And then, of course, severe pulmonary hypertension. However, a graft rejection remains a major challenge, and it requires a lot of monitoring and immunosuppression medications. So they keep a close eye. The transplant surgeons keep a close eye on these patients. So indications, some of your indications for lung transplant, some of your primary indications, like we said, with end-stage lung disease and poor prognosis, they have a less than a 2-year survival rate. They have severe functional limitation despite maximal therapy and failure of conventional treatments. And then these are the common diseases listed out here. It could be for your IPF, your COPD, etc. The transplant type could be single or bilateral. And then they look at the criteria depending on what the diagnosis is. Are they doing a single or are they going to do bilateral lung? And then your CF and your pulmonary arterial hypertension always require bilateral lung transplants. Like your and your IPF and COPD may only receive a single or bilateral as listed on the table here. Some coding considerations regarding provider terms. They'll say lung transplant failure or rejection, and they may be ruling out. They may say rule out, lung transplant rejection or failure. So you want to make sure that they clarify it if it's confirmed or not. And that's a possible query for you. Diagnostic workup. They're going to do PFTs. They're going to do bronch too, because they want to see if there is a failure or a rejection going on. They need a piece of that lung tissue. So they're going to do a transbronchial lung biopsy besides your imaging x-rays and possible CTs. Treatment usually is high dose IV corticosteroids or high doses and higher doses of oral immunosuppressive medications. So they're going to hit them with both barrels. And that's why usually they're within the hospital for a period of time. And then here are your T codes for failure and rejection. Key documentation points, type of rejection. Is it acute cellular rejection? And that's what they can find out with the lung biopsy. Or is it a chronic allograft dysfunction, CLAD? How severe is it? Is it mild, moderate, severe? What's the timing? Is it less than a year that they just had the transplant, or is it greater than a year? Is it a later complication that developed? And then what other complications may be in there? Is it a graft dysfunction? Is it primary or secondary? And the BOS, the bronchiolitis obliterans syndrome that they develop because of it. Like I said, usually it's high doses of immunosuppressive therapy. Also, they may even do a plasmapheresis if it's an antibody-mediated rejection. So look for that too, because if it's an antibody-associated mediated rejection, they're going to be doing plasmapheresis on that patient for quite a few times. And then, of course, your CDI queries, whether the specificity of the severity of a rejection, or is it a chronic rejection? Have the immunosuppression meds, have they intensified or they modified them? Did they increase the dosages for those patients? So keep an eye on that. And then lung transplant is indicated for end-stage lung disease with poor prognosis, and usually your survival rate is less than 2 years. Unfortunately, I've seen some patients who had a lung transplant, and then the following month they came in with rejection. And unfortunately, they ended up going on hospice services because they could not get another lung transplant. And the rejection was just overwhelming the patient's body. And it was a young guy too. Unfortunately, he was in his 30s. Very sad indeed. So you definitely want to keep an eye on these patients. Any transplant for that matter too. It can happen. And then here's just a clarification query sample, when you modify it accordingly. Any questions on that? Oh, is Chrissy sharing?
It's good information because I didn't know about the plasmapheresis for that.
Yeah. I think it's really important. Christy, where are you? Okay, Christy, are you sharing or am I sharing? You guys still see my screen?
I see the query sample.
Okay, you guys see it all right? Okay. Thank you, Patty. All right. I'm doing the sharing right now, Christy, so we're good. So unless she's, well, let me stop sharing then. Or Christy, I think you are sharing. Okay. You want to go to the next slide then, please? All right. Okay. Quality documentation challenges. As we all know and love, documentation is affected by SOI, ROM, RAC audits and compliance, your POA status, profiling of hospitals and physicians, which is part of your value-based purchasing program that we're going to get into. Of course, your medical necessity length of stay. That's why you work with the case management department or care coordination department in your facilities, and of course, reimbursement. Once you get quality documentation, the reimbursement follows, as we all know. Okay. So when it comes to the old adage, if it's not documented, it didn't happen, and we know that, right? So there's a gap between the physician documentation and coding language. A lot of providers still doing that shortcuts with documentation, that copy-paste phenomena. And I wish that would slow that down a little bit, but we really, with all the current contract I'm working with, they go after the docs. Their physician advisors say you didn't document, you didn't update your assessment and plan. And then they give them 1 day to update that progress note. And if they don't, they put them on medical record suspension. So they're really aggressive, the healthcare organization I work for. And I think that's great. It's like they need to do what they need to do. Absolutely. And then, of course, impact of documentation is not known. And then practices really aren't taught. Coding practices aren't taught in medical residency, but some schools have initiated some coding classes for the providers. Okay, key responsibilities of a CDS, accurate diagnosis documentation, right? That's the key. We want to make sure everything is specified out to the nth degree. We query the providers for the specificity if it's not documented. And this way we support the proper coding and reimbursement, and it helps save the coders from sending queries in the end result. Okay. And we want to prevent down coding that may lead to financial losses for the hospital. Next, key responsibilities, ensuring compliance with clinical criteria. You want to make sure that you align everything, right? Your clinical indicators with what's listed in the record. And please ensure that a pneumonia diagnosis must meet the CMS, CDI, and Joint Commission standards. And all these guys, the providers know what the best treatment is. They go according to what the gold standards are, right? For treatment of every diagnosis known to man. That's what they're taught. That's why they have MD after their name. You also want to facilitate communication among care teams. Like I said, we work with case managers. You work with physicians, with the nurses on the nursing units, with the coders, but even with the therapist, right? If they're involved in the case. The nutritionists are always involved when it comes to a malnutrition diagnosis, right? You want to make sure that RD did a complete assessment, or we don't, at the current hospital I work for, they don't code it. If there's no RD assessment within the record and the RD says that they do not have diagnosis of malnutrition, that malnutrition diagnosis is not coded. And they made that a hospital-wide policy because they have 6 different facilities as part of this organization. You always want to identify gaps for quality metrics. So that's really important.
Do you mind repeating what you just said about if the RD said something, you're not going to code it? What was all that? Sorry.
That's for malnutrition, Jeannie. So if the RD stated that the patient does not have malnutrition, no malnutrition diagnosis, the coders will not pick up that diagnosis on final coding.
Oh, so you're
Because
saying the doctor documented that they do have malnutrition.
Right.
dietitian
And the
said
RD says no.
I would
Correct.
think they would be required to send a conflicting diagnosis. How can you can't? That's kind of shady.
We would send it. You know,
Oh, okay.
from a
Gotcha.
CDI perspective, yes, I
Okay.
would send it. However, based on this hospital organization, I don't, based on their hospital policy that they set up.
Okay.
So, you know what I mean? So that's the thing. You always got to go back to what healthcare organization you're looking at. I understand. In that respect, I agree that I should be sending that query. But they don't want you to at this organization. So I get a little leery with that because it's like, come on, you want to be transparent with everything.
Right.
And you don't want to get the coders in a situation because they're certified and they have to go according to their rules, right, and regulations. So I said, you guys really need to rethink that.
Yeah,
And
doesn't seem right. What we found where I'm at is that the dietitian on their assessment, they have moderate malnutrition or severe malnutrition. There is no option for them to document mild. And so there are times that, the doctor might say that they have malnutrition, and, that can, as long as they're not saying moderate or severe, then we definitely do take that because we would send a query just to clarify, please give me your rationale for why you believe they have malnutrition, doctor, and he certainly can give it. And I'll just throw out one other thing I recently learned, because we're really big on the whole Vizient thing, is that, any degree of malnutrition or failure to thrive counts as the Vizient variable for malnutrition. So I have queried for failure to thrive once because it was just so obvious and the doctor didn't say it. I don't think I would do it too often.
Right. But isn't cachexia part of the Vizient model as well?
That is a separate variable, but yes.
It's a separate, right? Yeah, it's separate.
Mhm.
It's not part of the malnutrition with the failure to thrive. Yeah, that's
Correct.
that's in the same grouping, right? So I remember I worked for a company just a few months. They used the Vizient model, and some of that Vizient model, it's all about quality data. I don't know, Patty or Donna, if you've heard of that. Not sure. Do your organizations have that Vizient model?
I haven't heard of it.
You haven't heard of it, Donna? Okay. How about Patty? Our quality team uses it. Okay, yeah. So there were some things in there that what they're grouping together, sometimes it null and voids some of your SOI and ROM data, your quality data points. So just that's why I'm a little leery with that Vizient model when it comes to quality data, because it can affect your SOI and ROM in a negative way instead of a positive way. So just FYI, what I've seen when I worked at that organization.
You might be thinking of the Elixhauser. So sometimes you can maybe like Elixhauser obesity actually is not a good thing to have. Like you don't want to code obesity because on Elixhauser that makes your score go down. But for Vizient, it will make your score go up. So I'm all about
maybe that's what I'm thinking about the Elixhauser, because you got to really, I mean, there are so many different quality models out there, and there's a lot of eyes on that claim form, right? As soon as it's gone, to the insurance, that claim form is sent everywhere. External quality organizations get a piece of it, so that's why you want to make sure that those diagnoses are pertinent to that patient's episode in the inpatient setting, and make sure everything is accounted for with clinical evidence on the record in order to say this patient did have this. Okay. And that's really a big piece of the pie when it comes to all these quality data. And we're going to get into PSIs and the HACs. So, all right. Okay. So the next slide here is why. Christy, you there? Okay, yeah. Why is this role important? Either it's undercoded, misclassified, or overlooked. So you really want to make sure you want to reflect the true complexity of a patient's condition, ultimately leading to better care and reimbursement. And then what we look at from this standpoint, elements of high quality documentation, as we all know, you want all these pieces listed to make sure that everything is correct and accurate. And then let's look for the 2022 AHIMA ACDIS Query Practice Brief Update. Like I said, they just did an update at the main ACDIS convention last month. Unfortunately, it's not all in here. I haven't updated it, but we'll get it updated. I will send you what they updated within the brief. And these are just, what client compliant query practices, your multiple choice, yes or no answers are usually used for POA. And we look at the three-legged stool, right? The query options, which is your clinical indicators. It's like your diagnosis, where was it found? H&P or consult note, progress note, what the diagnostic workup was, and of course your treatment plan. You always want to use the clinical evidence in the record. Yeah.
So a quick question. We recently were having some issues on queries for some like sepsis, some pretty major diagnoses where things were not clear or weren't able to get to the chart in a timely fashion, needed to figure out if they were POA or not. When we were discussing queries, like I sent one to clarify the sepsis and the POA, our format, Anne-Marie knows in our format, it always includes, is this POA or not? Even when you're not asking for a POA status. And the doctor wrote no. And then it was then discussed, do we remove that aspect? And it's not a POA query. It's clarifying, one person said sepsis, one person said severe sepsis. What do we have? And it's just included as part of what they need to reply to. And they were saying we should remove the POA status. I about lost my mind because I don't think that that should be removed. And I just wondered if you'd heard anything on that.
Well, honestly, if it's going to confuse the provider, I would remove it. Because if they give you a non-POA for a diagnosis like sepsis, and, you know, did the patient come in the door with that? I mean, and if they came in the door with it and it was POA status, and they're saying none on the query template, and you're not asking for POA on the diagnosis, you're just asking for clarification if it was right.
Right. Well,
See,
this particular one was twofold, meaning I didn't want to do two queries for it. So I kept, and obviously, okay, by what you're saying, that would be the appropriate thing to do is keep the POA in if you need both things clarified, but maybe not have the POA if you don't need that aspect clarified.
Correct.
Okay. All right. That makes sense.
I would do it that way because you know what, you can, if a diagnosis is clearly POA, Patty's saying something here. I don't have the chat open.
If diagnosis is clearly POA, documented as such, written within 24 hours of admission, we would not include POA question. Okay.
Then the query, right? Okay.
All
yeah,
right.
and that's the other thing.
Like a newer thing to me, and my mind wasn't quite wrapping around that.
Right. So I'll give you another example. If a patient came in, the H&P never said that they were diagnosed with sepsis, and this is where my current organization is, where I'm working currently. Okay, contract company. The patient was admitted for aspiration pneumonia from a nursing home, had a stroke and this and that, you know, elderly person. All of a sudden they started writing sepsis on the next day, hospital day 2. Since it wasn't documented in the H&P as a rule out or possible sepsis, I have to clarify that sepsis diagnosis that's POA or not POA. So some facilities, bottom line is some facilities do not go according to the 48-hour rule if it's documented within the first progress note and the H&P. Others won't. Okay. So you have to clarify if that diagnosis was present on admission or not, since it wasn't mentioned in the H&P. And Jeannie says she agrees with that. And that's what you may see when it comes to POA status. So you got to really know your facilities. Right. Sepsis is so often, you know, I agree that, you know, it's definitely, you got to keep an eye on POA status for a lot of those, you know, I call them red flag diagnoses, and sepsis is a big one. Okay.
Also, like in the previous facility where I used to work, it's a separate template, like POA, only POA, and then, you know, sepsis is just sepsis. So I think if there is a doubt about POA, then, you know, you have two queries then, if that would be the case. So but we do not put the POA on the same template as the sepsis. So,
well, if you're clarifying sepsis and trying to clarify POA, the POA status, why would you not include that versus sending the doctor two queries?
Because what happens is if they give two different answers? So it's going to be, I know it's going to be like a burdensome for the doctor to have two, but if you're going to include POA, they would, you know, when they read it, should I answer POA or should I not answer POA? Because, I mean, that's how we do it in the, you know, previous facility where we work. So we separate, POA is a separate template for us. And then, for example, it's pneumonia. So if it's not POA, then, you know, we don't use you know, it all depends on the situation, but we don't put it on the same template.
Yeah, because our templates, as Anne Marie knows, every single query
The POA.
the POA, then
Yeah.
to distinguish the POA status.
Yeah.
See, and Patty brought up a good point too in the chat that we have two separate query templates, and you do have a sepsis admission status, right? For
Mhm.
POA or not POA.
Yeah.
And I think it's really important to understand that, you know, that's why I always say, go back to what your hospital policies are when it comes to queries, because maybe they need to be updated or tweaked a little bit, you know, say, okay, now we're updating some of these query templates. Okay, we need to look at the policy. You know,
Mhm.
does that need to be updated for current times? You know?
Yeah. Yeah, it's true.
Especially since you don't want to ding the hospital either.
Yeah.
Well, that's it.
Mm-hmm. Yeah.
Absolutely. Okay.
Mm-hmm.
All right. Well, like I said, I'm not going to read through all this, but I think, what's the other slide that we have in here? Christy.
It's all the 2022 AHIMA ACDIS practice.
Yeah, and when not to query. Yeah. So like I said, I will go ahead and email everybody once I get the updates. And everybody will have the updated information. Like I said, I never had a chance to do it being out of the country last month. So, okay. And I think we're down to our case studies now.
Okay. So case study number 1, 78-year-old male admitted for shortness of breath, known history of obstructive chronic bronchitis, COPD, on home O2 at 2 liters. Patient's oxygen saturation was 94%, 2 liters at home. Workup revealed the following: chest x-ray, no acute infiltrate or vascular congestion noted. The CBC 12.5, H&H 9.8 and 31.2, respiratory viral panel plus COVID virus PCR test. Attending provider H&P indicates the following: 78-year-old female with known diagnosis of COPD, obstructive chronic bronchitis, dependent on home oxygen, presented with shortness of breath. Physical exam revealed expiratory wheezing throughout, diagnosed with COPD with acute exacerbation, acute bronchitis. Check respiratory viral panel, COVID-19 PCR, and chest x-ray. Supplemental O2 at 2 liters to keep saturation O2 at more than 92%. Hospital day number 2, attending provider noted in progress note, positive COVID-19 virus, likely cause of COPD exacerbation. Initiate IV dexamethasone, continue supplemental O2 at 2 liters, and short course of IV corticosteroids. So what would be your PDX here?
The COVID.
I put COVID.
Yeah, I would think it would be COVID because after studies, it's actually the COVID.
Well, and the guidelines say, you know, with what the cause could be and what are they treating the most.
Yeah.
So, you know, they're on O2, they're on the other meds for the COVID.
For the COVID, yeah. The dexamethasone. Of course,
They
the
did
O2.
remdesivir, which it doesn't say if they did.
So for now, right, with this documentation, we could say that COVID is the primary diagnosis, right? So do we have a secondary diagnosis here, CC or MCC?
Okay, without exacerbated. Well, the acute bronchitis.
Okay.
And COPD exacerbation.
That would be your CC, right?
Yeah.
Mm-hmm.
And you definitely have a query opportunity.
Patty just put it in the chat. Here you go.
Yeah.
So of course we have query opportunities here. What would it be?
Respiratory failure for one.
Is it gonna be yeah, respiratory for one. I'm not gonna ask for acute, right? Because
No, they're on the same baseline HOMO2 they were.
yeah, that's right. But the patient is has COPD, so we could ask for chronic. And usually COPD is what is it? Hypercapnic or
I was just gonna say we don't have an ABG.
no, we don't have an ABG here. But yeah, we could ask based on the history of COPD as well as when you get the ABG, probably you could ask for the type of the respiratory failure. And like I said, the patient has acute exacerbation of the COPD, but it doesn't have a clinical indicator to suggest that it is an acute respiratory failure, right? So it's going to be more or less chronic, because we don't want to what do you call this, offer something that doesn't have a clinical indicator. So we just need to know
Criteria.
yeah, the respiratory failure and what type it is based on the ABG result. Anything more?
Mhm. No infiltrates. We don't have no pneumonia at the moment.
Mm-hmm.
Gal, speak up.
I don't see anything else. There's not like indicators for sepsis. Looks like it's
Yeah,
pretty basic.
yeah. For now, the documentation will only with this documentation, the only thing that we need to query is actually the respiratory failure, right? WBC is not really that elevated, but you know, and it doesn't have any indicator for, like you said, sepsis or any kind of infection. Very good. So this is just a sample query for chronic respiratory failure, right? So we have the clinical indicators, the chronic bronchitis and COPD with O2, and then the chest X-ray is negative for infiltrate. So we're not looking for infection there. And the patient is on supplemental O2 and home O2, IV, dexamethasone, and IV solumedrol. And these are the choices that you're going to give. Like I said, I'm not going to put acute because there's no clinical indicator for that one. So, okie doke. And the trigger words here are the chronic lung disease with home O2. So anything that if the patient has chronic lung disease, COPD, pulmonary fibrosis, interstitial lung disease, and the patient is on home O2, maybe we could think about asking for chronic respiratory failure as well. And the treatment also includes the breathing treatments. Okay, case number 2. 52-year-old female, direct admit to the hospital for increasing shortness of breath, has pulmonary fibrosis, and has been oxygen dependent for the past year with advanced pulmonary fibrosis, idiopathic pulmonary fibrosis spelled. Patient's O2 saturation was 84% on 4 liters, her baseline. She increased her oxygen level to 6 via nasal cannula, and the patient's saturation only reached 86%. Patient contacted her pulmonologist and was instructed to go to the hospital as a direct admit to the medical surgical telemetry unit. Her pulmonologist met her at the hospital to admit her. Workup revealed chest X-ray, fibrotic areas that have increased compared to the last chest X-ray on March 2. CAT scan of the chest suggestive of increased fibrotic areas in the lungs. Attending pulmonology H&P indicates admitted with ILD flare, crackles, and diminished breath sounds noted throughout her lungs with occasional hemoptysis. Initiate IV steroids, maintain O2 supplement at 6 liters to keep saturation above 90% for her chronic respiratory failure. Start Xanax for generalized anxiety disorder, chest X-ray imaging every other day. So what's your PDX?
It's currently pulmonary fibrosis, but I would be asking for acute respiratory failure because pulmonary fibrosis is probably a horrible PDX to have.
Yeah,
I would query for acute on chronic because the patient has.
Exactly.
that's right. Yeah.
Definitely.
I agree.
Uh-huh. Yes.
Yeah.
So right now we have the exacerbation of the interstitial lung disease as your PDX, right? And your query opportunity is the respiratory failure, right? Because baseline O2 is 4 liters, they increase it to 6 liters, and it's only 86%. So I would query for that. And then, you know, if they do an ABG, and so that we would, you know, more specific for the type of respiratory failure. So is that it?
Secondary would be the hemoptysis, which then you need to watch and see what the echo says if they have hemoptysis.
That's right. So
Ooh, what are you thinking of on that to be looking for on that echo?
Seeing if there's possibly any underlying CHF that maybe hasn't been diagnosed with all the
yeah.
lung issues and.
Very
Right, good call. Yeah, thanks.
Because sometimes they come in with all that and it just might not be documented, but you look at the echo and you're like, oh my goodness.
And especially if they're on some diuretic at home.
Yeah.
You know, that's why you want to take a look at their home meds all the time.
And they got crackles. So.
Very good.
yeah, I mean, they're doing the chest X-ray imaging every other day, so it might come out, you know, on
They
the
might end up putting some fluid on the lungs in there.
yeah, fluid overload there. So
Right.
we want to see, check that out, and like I said, follow up the ABG for the type.
And unfortunately, if she's my patient, she dies because all of my patients are dead. I only do mortality. So sorry.
Okay, so you're doing mortality, yeah.
Oh, that's bad.
That is,
That's not a Pam or Patty.
yeah.
Yeah. You may be reviewing her record upon expiration.
Yeah, I don't want to do mortality reviews.
I know.
for some reason.
Oh my God. And also, since the patient's occasional hemoptysis, they don't really know how much it is. I'll just have to follow up the H&H and see if something, you know, is
I see
going
if there's
on with
any-
that one. If there's like blood loss or they're treating it.
It could be anemia of some
Yeah.
sort.
Yeah. Mhm.
Or- and if they're on any anticoagulants for some
That's
reason that
right,
we
yeah.
get a little bit, yeah.
Yeah, so you check the medication. So that's why it's very important when reviewing the chart is to review the to review it concurrently, because you get more information with the concurrent review, as well as the follow-up labs and chest x-rays. So very
I
good.
find it is also so helpful to read the EMS report. That always gets it's like a game of telephone, how everything changes, but I get so much information from EMS. It's remarkable.
Yes, yes.
ED too, because I keep saying in our department, or for me, that and I've been working with some of our ED docs, that ED note is huge. Because this is how they're coming in the door. This is what you're doing to treat them coming in the door. Not that our attendings take forever. They don't. They're usually, fairly timely in their HMPs. But you're going to have treated this patient most likely before the attending ever sees them, which means sometimes the attending notes is better and reflects the fact that they were treated. But we need those notes from them as well to back up also what the ED did.
Yeah.
And a lot of times the ED doc addresses a lot of those acute things, and their respiratory, they might be in the ED for a good 2 hours or probably more.
Yeah.
They've treated that acute respiratory failure, but by the time the admitting hospitalist sees them, it's not there. But if they treated it in the ER, it counts, and we want to make sure that we capture that. And so it's so important. I don't know where I got this idea from, but apparently when I first started CDI, I don't know if somebody told me this or I just got the idea that we just didn't code from the ED note. And then only in the last couple of years, I realized, no, we can and should code from it. You need to look for, if what the ED doctor says doesn't get carried forward, well, that could be a problem, and you better query it. But on those cases when they're, for the dead people, they're there for a day or two, that ED documentation is so invaluable because the admitting doctor just didn't see that. So we definitely.
A lot of times on my queries, we'll bring in some of those notes.
That's right.
Our hospitalists are really good. We have a couple community doctors that stink, and that's just how it is. But you got an ED documenting, they're in tripod position, they're in this, they're da 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 da, and then your H&P from that community doctor isn't
addressing
it helpful. It isn't really representing that. And if I have to query, I'll bring in that ED note because that's how they presented. They were treated. They were admitted. The attendees are not gonna they had one DSAT and their shortness of breath and tripod, da da da. And it used to be that one DSAT wasn't enough. It's not one and done. Well, they're also not going to let them sit there and DSAT more. So
that's
right.
Going
to treat them.
Yeah, and also once Jeannie said, sometimes they stay there longer, and they give them for example for respiratory, so they give them IV
breathing treatment, diuretic there. Yeah.
It will settle. So when the patient gets admitted to the floor, that's no longer a huge problem, but it was a problem in ER. So, and then they get admitted as an inpatient, so it should carry out, it should carry on. Or if it's the doctor's not documenting, then we could query based on the ER documentation.
So their notes are huge.
Oh yeah, even the EMS. I mean, their notes. Yeah, I read that.
You'll see that in the ED note. Well, the EMS, they gave them this, they gave them this, they gave everything treatment en route. They gave so they're starting to treat them as well before they even get to the ED.
Yeah. And like the AutoSat, when the EMS came to the house, what was the AutoSat at that time? So
It's helpful to have all the information to paint the picture.
That's right. Yes, very good.
Patty even mentioned too, like the same issue at Jeannie's facility for unknown reasons. We were always taught not to code from the ED, but you can capture stuff from the ED. That is part of the coding. The coders guidelines too, coding guidelines. And there was due to a misunderstanding of rules by the coding team, which was then taught to all new CDI team members. Yeah, absolutely. You can get a lot of a wealth of knowledge out of that ED provider, especially if they're on top of their game and they know what diagnoses to specify out.
That's
right.
And
they're doing so much better in our ED. It's really, I think they have education outside of CDI. There's something that is helping them, because not that they were ever really bad, but Anne Marie knows there's a lot of times when you didn't get a full picture. And there's something else coming down, or I don't know what, but they are doing a lot better.
Yeah, because I remember when I started CDI, that's what they said. You cannot, since it's an outpatient in ER, you cannot code it. But I mean, I think lately that's, it's okay now. I mean, based on,
or at least if you're using information to clarify in a query.
That's right. So
we want to see those attendings bring it in. We don't want to just have it be the ED. So by querying, then you can get them to also
bring that information. Yes, that's right. Yes. So, okay, so this is just the sample query for the acute and chronic respiratory failure. And like I said, just wait for the ABG, so we'll be more specific as to the type. Okay. All right. So
It
this,
helps with POA status. Yeah, absolutely, Janie.
oh yeah, the POA, yeah, and the POA status is important also with acute respiratory failure, because if it was present in ER but got better when the patient went to the floor, I mean, you could, get that information from ER notes that say is, per ER, the patient is this, this, this. Is it present in their vision? Can you document, because most of the time, the doctors will just, document what they see at that moment. So very good. So here are just the trigger words for acute and chronic respiratory failure. Like I said, the ABGs, watch out. What are the ABGs? And if the saturation is less than 88%, if the patient has chronic respiratory failure, or the patient is at least 4 liters on BiPAP or ventilator, and if the doctor documents respiratory distress, shortness of breath, dyspnea on at rest or on exertion. And like I said, that's specify the type based on the ABG, which is going to be a clinical indicator. And the treatment is, oxygen, at least 4 liters, ABGs, vent support, and BiPAP. While the chronic one, the patient has a chronic lung disease with home O2, and like similar to acute, is it hypoxic, hypercapnic, and O2 supplement at home with breathing treatment. So if you see this documented in the chart, then it will trigger you to ask whether it's a respiratory failure. Okay, so this is case number 3. This is a 67-year-old male presented to ED complaining of dyspnea at rest with severe dyspnea with any movement as well as positive yellow sputum. Known history of COPD, not on home oxygen. Patient informed ER provider that his wife has been combating a flu virus and think he might have it. He uses a albuterol inhaler without much relief. Patient then contacted his primary care and instructed to go to ER. Workup revealed, physical exam revealed inspiratory and expiratory wheezing, O2 at 76% on room air, placed on high flow oxygen upon his arrival in ER. Chest x-ray is negative for acute pathology, vital signs 99.5. For temp, pulse is 103, respiration is 28, saturation is 76% on room air, and BP is 143/88. Attending provider diagnosed the patient with acute COPD exacerbation, likely acute bronchitis, as chest x-ray is negative. Respiratory panel pending, pulmonary consulted, started on IV corticosteroid, Xopenex nebulizer treatment, and additional recommendations from pulmonology. Pulmonology consult is 67-year-old, presented with increasing shortness of breath, dyspnea and exertion with sputum production. He informed me his wife has been combating a flu virus and think he might have it. Diagnosed with COPD with acute exacerbation, likely triggered by exposure to flu virus. Respiratory viral panel pending, continue IV corticosteroid, Xopenex, and high-flow oxygen to keep saturation above 92. Hospital number 2, pulmonary progress note indicates patient feeling better, still shortness of breath at rest. Respiratory viral panel positive for influenza A, will begin Tamiflu, continue IV steroid, nebulizer treatment, switch to BiPAP settings, and notified respiratory therapy. So I think it's the same thing. Okay, so what is our primary?
There's another piece, I think, babe. Go to the next slide.
Oh, okay. This is the sample
Yeah,
query.
there we go.
This is the same thing.
Oh, it is. Okay.
So what is your primary diagnosis here?
Influenza A.
Okay.
I think, would it be COPD exacerbation coming in the door?
In the door, but they tested him for influenza, and after study, that's positive. So they said his COPD is exacerbated by exposure to the flu, which means nothing. But then once it's positive, then I'd say that's your PDX. And COPD exacerbation is a horrible PDX.
Yeah.
Yeah, so because with the pulmonologist saying that the flu could have exacerbated the COPD, right? Yeah, triggered by exposure to flu virus. So this is the cause and effect, right? So the flu virus was caused by the COPD exacerbation. You agree?
The exacerbation is caused by the flu.
This one, yeah. Mm-hmm.
And they're treating with Tamiflu. So yeah, that was the trigger. And COPD is a chronic diagnosis. So if you have an acute diagnosis, then that's more likely to be your PDX. I think we also have possible indicators for acute respiratory failure, which could potentially be your PDX, but probably not a good PDX in this case.
Mm-hmm. Mm-hmm.
But he is progressing now. And if he ends up needing eventually to get intubated, then frankly, acute respiratory failure would be a perfectly good PDX.
So it all depends on on the succeeding notes. But for now, since on hospital 2, it was positive for flu virus, and per pulmonologist, he thinks that it's the flu virus that caused the COPD exacerbation.
And
So,
you can take the influenza too with respiratory manifestations too.
yeah, that's right. So yeah, it would be the
Sorry, I
flu.
was talking away while you were asking questions and I didn't unmute myself. I'm like, well, it was a waste of
It happens. Yeah.
And then the query is going to be right, the acute respiratory failure. Patty mentioned that in the chat, and that's what we just discussed. So, yep.
Yeah, but right now you can't query for it because nobody's mentioning it.
Yeah, nobody's mentioning it. The O2 sat is 76%, right? And
you have evidence of treatment though, so you can, because doc, we got this patient on this much oxygen and we're using BiPAP now. What's the diagnosis? What's their respiratory status? Is it acute respiratory failure or is it maybe something else?
Right, but you're introducing if they don't mention it.
No, you're not. In that respect, you're not, because they're treating it. So you got the clinical evidence in the record to support the diagnosis, to pose the question, Debbie.
Mm-hmm.
So you're not introducing something. You're asking them to clarify what they're treating. Okay. So yeah, you may be saying, well, is it an acute respiratory or is it something else? Okay. And that's what we want them to clarify, because based on the clinical evidence in the record, they are treating a acute respiratory failure. Okay. Does that make sense, Debbie?
It does, but I'd like to see how you query that. Like I'd like to, do you have an example of that or no?
Let's see if we have.
I don't know if we do or not, if I put it
Here.
in there.
We have
I can give you an example. I would say,
here.
O2 status 76% on room air, treated with high flow O2. This is the stats. This is how it improved. Now we're on BiPAP. Is this acute respiratory failure with hypoxia on admission? Is it something else?
A query right here. So yeah, I like what you're saying, and then this as well.
Because you're giving them the clinical evidence in the record in order to support that acute respiratory failure diagnosis. And Patty even said what condition is being treated by all the clinical indicators listed. So, there are other queries out there that are available, because you have treatment, but you have no diagnosis to correlate with the treatment that's being performed. And you want to make sure you capture that diagnosis.
And like in this query, you have 3 choices. So you're not really leading the doctor on documenting this, but you're telling them, is this acute respiratory with hypoxia, or is it COPD without acute respiratory failure? So yeah, so you're or specify other explanation. Yeah,
right.
So, yeah, you're not leading them by telling them that that is the diagnosis. So
yeah, diagnose patient with acute respiratory failure or else. Okay.
Document this now.
That's it.
So anyways, yes. So that would be the acute respiratory failure possible query. on this patient.
I like that because
Mhm.
that's not how I was taught, so it's uncomfortable. But seeing this query helps it become more comfortable to send it.
To send
Okay.
the doctor, because you're giving the doctor the choice, right? So,
Right. Absolutely.
mhm.
Okay.
All right. So now here are,
Uh-oh, hands are raised.
Gee.
Sorry, I didn't mean to push every single button before, but I was just going to say, I'm going to tell you, somebody mentioned feeling uncomfortable with querying a certain way I won't name where I'm at currently, but for a while now, the policy at this facility has been, or at this healthcare system, has been to, and of course, the query practice brief says only give valid options
Yeah.
in your query exam. Of course, we know this. We're not going to give it but what we were doing is like the example that was shown, saying COPD exacerbation without acute respiratory failure as an option. But if my doctor gave me that as an answer, and I clearly have the indicators to support an acute respiratory failure, well, then we would escalate that to the physician advisor. Well, we don't really have a physician advisor anymore to do that escalation. And so it became decided that here's the uncomfortable part, that we would only give the options essentially if, this is what we have indicators for, and these are the only options we're going to give. So we wouldn't even give that second option, but the thinking was under other, that's where the doctor could say, no, there's no respiratory failure. It's COPD without respiratory failure. We all know that's not going to happen. The doctor is going to click a box. That's all that's going to happen. So it's a very uncomfortable feeling. We've been doing it for a while, and I'm a contractor, so I don't work for that healthcare facility, but I do imagine at some point something's going to get kicked back, and that's going to be.
It's like another query sample for like malnutrition, Jeannie, right? You only give, is it moderate or is it mild? And then you give other explanation of clinical findings, right? And I know a lot of people, that was at a previous contract I worked at, and they were like, no, you only give that option and the other, and that's it.
Yeah.
So that can be tricky. Absolutely.
Because you don't want to get dinged for leading. So
No. And also that's why our manager is doing those audits to find out whether we're, providing leading questions, and he corrects or she corrects us if that's the case. So yeah, but I was told as long as you give them options, that's not a leading question. All right, so these are the trigger words. We already went through this already in the previous slide. So let's go to the case study number 4. This is a 46-year-old admitted with hemoptysis, persistent cough, and an intentional weight loss of 15 pounds in 1 month. Only known respiratory history is asthma, which has been stable for the past several years. Rarely uses her albuterol inhaler. Pertinent history includes left breast cancer, status post-chemo radiation, and left breast lumpectomy 2 years ago. Has been on tamoxifen for the past 2 years, and she is a non-smoker. Workup revealed chest X-ray showing density in the right middle lobe, suspicious for malignancy. Recommends CT chest for further delineation. CT chest confirmed presence of tumor. Pulmonologist performed bronchoscopy with transbronchial biopsy of the tumor. Pathology report indicates metastatic lung CA, likely from primary breast cancer. Attending provider diagnosed patient with hemoptysis with persistent cough and weight loss, concerning for lung cancer. CT chest confirmed lung mass tumor in the right middle lobe. Pulmonary and hematology oncology consulted. Pulmonary notes, 46-year-old female, presented with hemoptysis, persistent cough, and intentional weight loss. Imaging concerning for lung cancer, prior history of breast cancer. completing treatment 2 years ago. Patient agreed to undergo bronchoscopy for definitive diagnosis of lung mass. So what is our primary diagnosis here?
Go to the next slide.
I'm sorry. Okay, pulmonologist performed bronchoscopy with transbronchial biopsy of the tumor. Pathology reports indicates metastatic lung cancer, likely from primary breast cancer. HACIMA consult notes very pleasant 46-year-old female presented with hemoptysis and intentional weight loss. CT scan confirmed lung malignancy. Patient underwent bronchoscopy with transbronchial biopsy confirming metastatic lung cancer, likely from the left breast cancer. She is a non-smoker but has been exposed to secondhand smoke from her husband and siblings. Discuss chemo options with her. We'll need PET scan to determine if other metastatic sites are found. Thank you for this consult. We'll follow up. Okay. So the PDX is
Lung cancer. Metastatic, Mets to lung.
mhm. Okay, so do we have a secondary diagnosis?
Hey, what were you going to say?
There's a secondary diagnosis.
Well, possible breast cancer. I mean, because there's no history of that.
Mhm.
So that would be one. We have the asthma.
Well, there is a pertinent history of left breast cancers that starts post chemo.
Oh, okay. I
Yeah.
forgot after.
Yeah, they said breast cancer on tamoxifen. Yeah.
Okay.
So that could be our secondary diagnosis, right?
We have
That's
asthma. Let's
yeah.
see, what else do we have? We have the hemoptysis. We need an RD consult for the weight loss because she could have cachexia and or malnutrition.
So that's our possible query, right?
Yeah.
The malnutrition.
Need to see her BMI and
Yeah,
what
we,
it says.
we have to see the BMI, and we need to see the what do you call this? The
It could be pulmonary cachexia with the cancer too.
yeah, and we need to see the dietary consult if there is. So we could use their assessment for the clinical indicator. Is this a medical or surgical DRG?
Surgical, because she had a bronchoscopy
That's right.
with biopsy.
When they did a transbronchial, then it becomes a surgical DRG.
Surgical.
Mhm. Because sometimes the pulmonologist will just say bronchoscopy done. And so, but then when you read to their op report, they went to the lungs, or when you go to the path report, they said lung biopsy or alveolar, or what's the other, parenchymal. So if you see those, lung biopsy, alveolar on the path report or parenchymal, then if the doctor just documented bronchoscopy, then you could query for transbronchial. Is it a transbronchial biopsy that was done, so that it becomes a surgical DRG, right?
Can you go to the next slide?
Mhm.
Next slide. Yeah. You want to go on slide 115?
Yeah, this is 115.
Okay, there we go.
Yeah.
So, is it so we know it's the other query opportunity is the pathology of that biopsy.
Very good. Yeah, you have to follow up the pathology because you don't even know, what do you call this? It'll be more specific if you have
Yes,
the path report.
specificity of the Mets to the lung.
That's right. Yes, it'll be more specific. So, some hospital that doesn't have the path report till the patient's discharged. But but some hospitals have they're kind of fast, so they have the report there. So that would be nice to find
And
out.
we have a lot of pathology queries for things like this.
Yeah. So
Okay. Are you guys seeing the current slide, which is 115? Patty, you seeing it? And Debbie?
I see it.
Donna?
Yeah, I see it.
Jeannie, you're still stuck somewhere?
Stuck on sample query for acute respiratory failure.
Oh,
Wonder if you should refresh or something. I don't know why you're stuck and everybody else is on the current one.
Probably it froze.
Maybe it froze
I
on
mean,
you.
I can see
Yeah.
the messages in real time and stuff. Okay, I'll log off and back on.
Okay.
Okay, see if that'll work, Jeannie. Okay.
So yeah, so those are the two possible queries, right? The malnutrition, wait for the RD consult, as well as what's the BMI and what are the treatment? Are they treating it, right? And then also, like Debbie said, what is the path report to find out more specifically the what do you call the type of cancer? Yes. Yeah, pathology. So, and also, if they're gonna do the PET scan, probably there will be more sites found. So we need to follow that up. And I think that's about it, right?
That's it.
Okay.
All right.
So this is acute respiratory failure. I don't think. No, I don't think it's for oh, no. It's a wrong title. It's for the metastatic lung.
For metastatic, not respiratory
Yeah.
failure.
Yeah. So this is just a sample query for
Metastatic lung cancer, just to confirm.
mhm.
Yeah. I don't know why it had that up there.
Mhm.
Okay.
Okay, so that is just and then and these are just the trigger words for the lung cancer, like usually asymptomatic with initial onset. Progressive disease may have symptoms of dyspnea, hemoptysis, wheezing, airway obstruction, compromise. Chest X-ray may show pleural effusion, and malignant neoplasm of the lung should be primary, could be primary or secondary, and you have the site, and then the lymph node, and the pleural chest wall involvement. So if you see this documented, then probably you could, trigger your mind that probably we could query for this one. Okay.
Right.
Okay, so case number 5. Are we good? Yeah. Okay,
Yeah,
so
we
this
good?
yeah.
Yep.
77-year-old male arrived in emergency room with increasing shortness of breath, wheezing, and increased sputum production through tracheostomy. Underwent tracheostomy 1 year ago for laryngeal carcinoma, status post-laryngectomy, and noted to have tracheomalacia post-operatively, thus requiring tracheostomy. He has been using his nebulizer treatment without success. Vital signs upon admission: tempo 100.3, pulse of 105, respiration of 28, BP of 102/65, and SpO2 on room air is only 86%. Placed on 4 liters with SpO2 increasing to 95%. Workup reveals chest X-ray shows consolidation noted in the right middle lobe and right lower lobe. CBC reveals WBC of 18.6, HNH of 10.8 and 32.2, platelet of 436, sodium 132, lactic acid of 1.5, respiratory viral panel is negative, sputum culture positive for Enterobacter. Attending doctor diagnosis include pneumonia, continued broad spectrum, antibiotics, pending sputum culture sensitivity, tracheostomy, status post laryngectomy. So what is your PDX?
Pneumonia.
Pneumonia, right? So any query opportunities?
Yes, to get the doctor to link the pneumonia to the Enterobacter.
Very good. So you want the pneumonia to be specific by linking the organism that's causing the pneumonia. So
Looks like we have indicators for acute respiratory failure, and there certainly could be an acute on chronic if we don't know if he's, normally on a vent at home.
These might be headed towards sepsis too, with some of the
Right.
information.
yeah, because of that.
For sure.
Okay. Yeah. With because we don't know we know that the patient has O2 sat of 86%, which is very low, and they place the patient in 4 liters, which is the minimum for like some facilities, like I think Amber was saying, it should be 8 liters to be considered acute respiratory failure. But
What?
but in our facility, 4 liters is an okay indicator for acute respiratory failure. So it all depends on what your policy is with regarding to the O2, of how many liters. So like Jeannie said, it could be acute respiratory failure.
Yeah,
And
'cause that's certainly not saying if he's on O2 at home. So
yeah, it doesn't say yes. And we just have a trach, but it doesn't say if it's, an event or
if he has O2,
Mhm.
He missed or P missed or something.
yeah. And Debbie suggested watch out for sepsis because it looks like the temperature is elevated as well as the pulse rate, and the patient has infection, which is the sputum. So and then the WBC is quite high, 18.6. And what is the normal for lactic acid? Is it?
Well, usually they say less than 2. It's not, but it depends on your
Okay.
doctor and how they feel about it.
Okay, all right.
Well,
All
it
right.
depends on your labs too, your lab, result, your lab testing. Because
Yes.
everybody has different normal ranges,
Mhm.
So
That's true too. Yeah.
usually it's less than 2. 2.0 is normal range.
Okay, all right. So yeah, so those are
Two.
the possible clinical indicators for sepsis. So if
They need to watch for, is that trach infected?
that's right. Yes, you find out, did they do any culture around the site?
Right.
Mm-hmm. And also the sputum culture is positive for Enterobacter, so we're good with that. But just around the area, did they do a
Yeah,
culture
they're
that one to find
well.
out? So yes, so those are the things you need to follow up for possible queries on this case. So let's just continue. Pending sputum culture sensitivity. So I don't know whether that's from the trach because there's already sputum culture, Enterobacter. So I mean the culture for the trach. So far we have the PDX as the pneumonia. We need to clarify for the type, which is the Enterobacter. We need to follow up for acute respiratory failure as well as follow up for possible sepsis. Now, giving that information, if the doctor documents the sepsis, let's say in the 3rd day, we could also follow up, was it present at admission based on the clinical indicators that we have. At the same time,
Present on admission.
yeah. Same thing as a respiratory failure. Was it present on admission? Because the patient had O2 of 86% on room air. So those are the possible queries on this short case study. Okay, so this is the sample query for pneumonia. So you have the 3-legged stool, you have the data, you have the treatment, and then also the labs. Okay, so just the trigger words for pneumonia, you have the symptoms of fever, chills, chest pain, dysphagia, or physical exam of Ralph's bronchi dullness. And then diagnostic, you have the chest x-ray, find out what it's the result is. And then positive aspiration for speech therapy. So if you see the speech being called and there's an aspiration assessment, so probably you could query the doctor. Of course, the treatment would be the antibiotics if the doctor orders a swallow study and O2 saturation, and the specificity, like if it's aspiration or is it bacterial, if known, and if it's treated with vanco and zosyn. Some hospital has a policy to query the doctor based on the antibiotic given. If this antibiotic is only for gram-negative pneumonia, then we at that time can query whether it's gram-negative pneumonia based on the medication. So, but it all depends on the policy of your facility, because sometimes the doctor doesn't want to really, document that unless they have the culture. So,
Well, a lot of times you don't even get a culture on pneumonias, meaning the patient has nothing to give you.
yeah, that's right. Yeah. Okay, so now we have the ICD-10 coding updates.
Okay, so we're not going to go through all of these based on time, but you all can take a look at them. These are ICD-10 CM and ICD-10 PCS is also in here for fiscal year 2025. So these are all updated. Okay, and this should be fiscal year 2025. Okay, these are all coding updates. We're not gonna go through anything because of time right now. But you can see there's quite a few different changes. And just go through them. And obesity is a big one, with some other muscle disorders. And PCS codes, they're putting in, let me see, scroll down, Christy. And they have the neoplasms, they have your social determinants of health, they updated. MIs, they've updated. Circulatories, and then PCS code changes. The big things, I think the new codes, if you click on the next one, this is all from AHA Coding Clinic. They're doing a radio frequency ablation of brain, some hepatic artery, splenic artery to lower artery bypasses they're doing now. So your vascular procedures, they put removal or revision of stents, whether it's in the gallbladder, this is hepatobiliary. Okay. And then biprosthetic aortic valve leaflets now, because there's a new technology. So if you have major cardiovascular services, procedures at your facility, look for these new technology codes. All right.
And make sure you're capturing the supersaturated O2 if you have a patient that's getting that with some of their cardiac treatments, because that's a new thing. It's there's a code for that. It's what's the word? Like a new treatment code thing.
Technology.
Yeah. Thank you.
Yeah, new technology. That's like with ECMO too. They added additional procedure, new technologies for it. So, okay.
I've had like 2 patients now with that super saturated O2 thing.
Yeah. Right.
Wow.
And then posterior fixation of the spinal fusion. So they added all these in. So these are all new technology. Okay, just FYI. If you do a lot of spinal fusions in your facilities, you may see these. Okay. All right.
Can I share
And all the
something?
references.
Jeannie,
what are you saying?
Uh-huh.
Or Patty, you have a question?
What's Deb? I have a question.
Okay, who has a question?
I do.
Yeah.
Okay, go ahead.
Okay. I just wondered if everybody else had this going on in their institution. So we now have a QA, a quality person consult. And we had a whole thing on this in one of our meetings. And the new language or the new way is that it's not considered a postoperative respiratory failure as far as a PSI if it's not a scheduled case. Like the doctor can document post-op respiratory failure, but it doesn't meet the PSI criteria unless it was a scheduled surgery.
Yeah, it's the same for us.
Okay, that was just new stuff, and I thought I want to see if anybody else is.
Yeah.
Jeannie said,
So, Patty, you have the same thing over there then at your facility then, Patty, right?
Yeah.
Yes.
Yeah, because if it's scheduled, yeah, I wouldn't think it would be part of the PSIs. And that's our next topic we're going to
No,
go
it
through.
is a PSI. It's not a PSI unless it's a scheduled case. Like, you know, your
Yes.
emergencies that come in, it doesn't get considered a
That's
PSI.
PSI, yeah.
Right.
And
Right.
we're gonna discuss that. The next presentation will be the, what do you call this? The PSI. Okay.
Do we need to take a 5-minute break?
I'm good.
Good. Patty, Donna?
I'm good.
I'm good.
Okay.
So
Good. Jeannie?
Listen
all right,
through.
all right. So let
Okay.
us know if you know, if you need some breaks. But we're gonna start, right, Anne Marie, on the PSI.
Let's do the PSI.
Okay. And if we go with if we extend longer than the 4 hours, we're gonna add that to the this number of CEUs. Okay.
Excellent. Yes.
Excellent.
Yeah, we'll give you more.
Okay. Now PSI. Okay. Let me share. Can you see it?
Yep,
Okay.
Yes.
good to go. Okay. So our learning objectives for this quiz, we're going to discuss what is PSIs. We're going to look at the impact on facilities in regards to patient safety and who in the facilities monitors the patient safety, descriptions of the PSI on hospital level indicators, examples of queries and how to avoid denials, and examples of the appeal process. Our disclaimers, I'm not going to read them again. You all know what our disclaimers are. So let's just delve into spot the mistake and take the action. So what is a patient safety indicator? They're a set of metrics developed by the Agency of Healthcare Research and Quality, or AHRQ, to help identify potential in-hospital complications and adverse events that might result in healthcare errors. Okay. These indicators are used for quality improvement, benchmarking, and hospital performance assessments. PSIs are used for quality improvement. Like we said, we identify areas for patient safety enhancement. So if we have problems with patient safety, we want to improve that patient safety so it doesn't have an ill effect on the patient during the hospital setting. It's used for benchmarking and public reporting. So we're comparing hospital performances, and CMS is a big piece of this with AHRQ to look at all this information and benchmark everything. It's also used for risk adjustment and reimbursement, and some PSIs will impact your CMS patient programs. That's the HAC reduction program. And we will discuss that in the last topic presentation of the HACs. So, role of patient safety indicators in the hospital. So we want to identify and address any potentially avoidable safety events, enabling them to improve care delivery, reduce harm to that patient, ultimately improving better patient outcomes and improving overall health care for all the patients in the hospital setting. So we identify problem areas. We focus on preventable events. It's all data-driven improvement. We look at benchmarking and compare, focus on your health, on your HACs. We're going to discuss that in further detail. And then we improve patient safety. So, using PSI to improve patient safety, it's enhanced by improving the care environment, right? So we want to make sure that there are, through changes of the electronic medical record and increasing staff awareness of risks, right? We don't want to put patients in harm's way when they're in the hospital. We want to help them improve and be better health-wise and get them discharged out the door, right? So there are some clinical interventions that help us reduce adverse events related to hospital care. And the PSIs help prioritize and evaluate these initiatives. We're looking at best practices from scientific literature. We're collaborating across disciplines to redesign care. We're looking at IT solutions, right? There's a lot of electronics right now with IT and implementing performance metrics for accountability. So when we're also looking at hospital-specific guidelines for risk adjustment. So PSI is part of your risk adjustment program, right? Your value-based purchasing, where your hospitals come into play. And then when you're dealing with PSIs, you're looking at hospitals to implement documentation of best practices, risk adjustment strategies to ensure accurate reporting and avoid penalties, right? Because hospitals will get dinged from a quality perspective if accurate reporting or best practices, all the documentation and risk adjustment strategies are not cohesive within the hospital environment. Risk adjustment ensures that PSIs reflect true quality issues rather than patient complexity. So you want proper documentation that prevents unnecessary PSI reporting. So some of these key risk adjustment strategies, your POA status is extremely important for all conditions when the patient is admitted to the hospital. And you ensure all chronic conditions are documented at admission. Query for providers if POA status is unclear. The other key risk adjustment strategy is your comorbidities and severity documentation. So it's not just about your POA status and your chronic conditions, but you want to make sure you capture all your chronic conditions and any acute conditions that bought the bed for them to be admitted in the hospital, to make sure you have an accurate reflection of the SOI and ROM data. Okay. Sepsis is a PSI 10, which is, it can have post-op AKI in there. So if a patient comes in with sepsis, and they may have AKI coming in the door as well, you want to clarify if that AKI is POA or not, okay? Or it may fall into a PSI 10, patient safety indicator, because we caused that AKI and we didn't prevent it, or they came in the door with it. So that's why it's really important to keep an eye on these items. Like your pulmonary hypertension too, that's part of PSI 11, which could be part of your post-op respiratory failure reporting. And then of course your CKD. Did they develop AKI with the sepsis and they need dialysis now? Or did we cause that AKI because we didn't monitor it or we didn't treat it appropriately when they came in the door, possibly with it? Okay. Some expected versus complication documentation. You want to make sure the providers are documenting correctly if it's post-op ventilation greater than 48 hours was planned, and then it wouldn't fall into your PSI bucket of 11. Also, if DVT prophylaxis was given, but the PE-DVT still developed, so you want to make sure that the providers are documenting DVT occurred despite appropriate prophylaxis to reduce the PSI impact. So certain key words like we look for in these, you definitely want to make sure that the doctor is providing that information and that it's accurate information so it does not fall into that PSI bucket. Okay. And you want clear surgical risk factors documented with patient-specific risks. Do they have a high BMI? Are they prolonged immobile? Are they bedbound? Do they have a history of DVT or PE? Are there expected post-op fluid shifts leading to AKI? Okay, so you really want to make sure that's documented by your providers. And then if there's any lung disease affecting post-op ventilation needs. Okay, the CDI action here is developing queries, ensuring these details are captured proactively to keep them out of the PSI bucket. Okay. So let's look at the provider letter, provider level patient safety indicators. Now, this PSI is mainly, I believe this is under the PSI 90 composite. Always keep this, that's right. There you go, Patty. That's the way to do it. So you always want to keep it, always have a cheat sheet of this on your desk, you know, because it'll give you some information. And this this is effective the version 2019, and the following indicator has been retired, the PSI 16 transfusion reaction count. They finally got rid of that because there's minimal adverse effects now with the transfusions that we're seeing, that CMS and the AHQR quality direct companies have seen. Okay. So exclusions. Now keep in mind, you know, PSIs, they have inclusion and exclusion criteria like your HACs do, right? So this is from version 2024. So this is the newer version for the PSIs. So PSI 2, the death rate and low mortality diagnosis, DRGs, excludes hospital discharges with trauma, cancer, and an immunocompromised state, and transfers to any acute care facility. So these patients are excluded from that PSI 2, okay? Your PSI 3 exclusions for pressure ulcers is length of stay less than 3 days, your principal diagnosis of stage 3 or 4 or unstageable pressure ulcer or DTI at the same anatomic site. Any severe burns are also excluded from this PSI 3, as well as a secondary diagnosis that was present on admission for your stage 3, 4, or unstageable pressure ulcers or deep tissue injury. Your PSI 4 death rate among surgical inpatients with serious treatable complications excludes transfers to an acute care facility or discharges admitted from a hospice facility. So these are all exclusions. PSI 5, retained surgical item or unretrieved device fragment count excludes discharges with a principal diagnosis of retained surgical item or unretrieved device fragment, and discharges with a secondary diagnosis of returned surgical item or unretrieved device fragment that was present on admission. PSI 6, your iatrogenic pneumothorax rate excludes principal diagnosis of non-traumatic pneumothorax, discharges with a secondary diagnosis of non-traumatic pneumothorax, that was POA, your chest traumas, pleural effusions with thoracic surgeries, including your lung or pleural biopsies, diaphragmatic repair, or potential transpleural cardiac procedures, as well as your obstetric discharges. So they're all excluded there. Next slide. PSI 7, your CVCs, related bloodstream infections. These exclude your principal diagnosis of central venous catheter collapse bloodstream infection, or it's a secondary diagnosis that was present on admission, and discharges if the length of stay is less than 2 days, and discharges with a cancer diagnosis or any immunocompromised state. PSI 8, in-hospital fall with hip fracture rate, excludes principal diagnosis of the fracture, a secondary diagnosis of fracture that was present on admission, a diagnosis of a joint prosthesis associated fracture, and any OB discharges. PSI 9, your post-operative hemorrhage or hematoma rate excludes your PDX again of your post-op hemorrhage or hematoma, or a secondary diagnosis that's listed as a POA status. Discharges in which the only OR procedure is for treatment of a post-op hemorrhage or hematoma. Discharges in which the treatment of post-op hemorrhage or hematoma occur before the first operating room procedure. Discharges with a diagnosis of coagulation disorder. Discharges with medication-related coagulopathy that are present on admission. Discharges in which thrombolytic medication is administered before or on the same day as the first procedure for treatment of the hemorrhage or hematoma. And of course, your OB discharges. Most of the OBs are excluded from all these PSIs.
Also, like if it's the principal diagnosis or the secondary diagnosis, so it's not going to be included in the PSI.
Right, because they're POA status.
Yeah, POA status, yes.
All right. PSI 10 for post-op AKI requiring dialysis excludes, again, the principal secondary diagnosis. Dialysis procedure before or on the same day as the first OR procedure. And dialysis access procedure before or on the same day as the first operating procedure. Any cardiac arrest, severe cardiac dysrhythmia, shock, CKD5, or end stage. And then any principal diagnosis with the urinary tract obstruction, as well as partial total nephrectomy procedure on a solitary kidney or an OB cases. PSI 11, your post-op respiratory failure rate excludes, again, your PDX or your secondary of respiratory failure diagnosis that are POA. If there's any diagnosis of a tracheostomy as well that's present on admission. Tracheostomy is the only operating room procedure in which the trach occurs before the first operating room procedure. Malignant hyperthermia or a neuromuscular disorder that was present on admission, as well as any degenerative neurological disorder. Any laryngeal, pharyngeal, nose, mouth, or facial surgery involving significant risk of airway compromise are excluded, as well as esophageal surgery, lung cancer procedure, or lung and or heart transplants, treatment of respiratory diseases in all OBs. And then your PSI 12, your peri-op PE or DVT rate excludes, of course, your primary or secondary diagnoses of a DVT that are POA. With heparin-induced thrombocytopenia, that's excluded. If they discharge with extracorporeal membrane oxygenation, that's your ECMO, where they discharge with acute brain or spinal injury, that was POA, as well as discharges where the first operating procedure occurs on the 10th day following admission, and then your OB discharges.
Going back to this post-op respiratory failure, because I did refer the patient developed post-op respiratory failure, was put on vent, and it was rejected by what do you call this, the one that is the quality people in the hospital, because at the time I didn't see that the patient has a history of interstitial lung disease. So anything that has respiratory diseases prior to let's say prior to surgery, then it's not included in the PSI. So if the patient has COPD and develop post-op respiratory failure, then it's not going to be included in the PSI.
Jeannie, you have a question?
Yeah, so in that situation, we always query for respiratory insufficiency following a surgery, because then, right, it won't trigger that PSI. But if a patient is on a vent greater than 96 hours, it's automatically, even if you got respiratory insufficiency and you don't have the words like post-op respiratory failure or acute respiratory failure, if they're on a vent greater than 96 hours, it still does trigger that PSI.
post the PSI 11?
Yes. Yeah. It's so unfortunate because I've only seen it happen maybe 1 or 2 times, but we're like, well, and that was our quality people were like, no way, this is, and all the right things were there. But if they're on that vent greater than 96 hours, that all those other things don't matter. It's going to be an inclusion.
Okay, and this is
Right.
post of respiratory failure.
Yeah.
Mhm,
Yeah,
mhm.
that's the unfortunate part with that PSI 11.
Oh,
That's like a lot of docs don't like writing that, or they'll write respiratory failure, but they're not going to give you any information. And, currently with this PSI 11, with this post-op respiratory failure, I know at the current company organization I work for, they're like, no, just code it as respiratory failure. Don't put unspecified. They don't even want you querying for anything. Because they don't want it going in that bucket in the PSI 11.
Yeah, and it's
So-
it's interesting because like on this second to the last bullet, treatment of respiratory diseases. So, I mean, if the patient's on a vent, I would think it would be a treatment, but I am not so sure about if it's more than, what is it? How many hours? 96 hours?
96, it's greater than 96 on the vent. Yeah.
Then
Yeah.
it's
It's going to be triggered into PSI 11.
Respiratory
Mhm.
diseases might equate to a chronic respiratory condition. That's how I took that.
yeah, I would, because
Right.
That's interesting.
Yeah. But it does trigger, Jeannie. Yeah. That's the unfortunate part with these PSIs. No matter how much you put in that it was, expected, or that, it was preventable this way, but it's still going to get dumped in there. Yeah. Okay.
Oh, sorry.
That's okay. All right.
Okay, got it.
Okay, PSI 13, your post-op sepsis too. Rate, of course, as we know, it'll exclude if it's the primary PDX of sepsis or a secondary diagnosis, that's POA. Discharges with a principal diagnosis of infection or a secondary diagnosis of infection that were POA, as well as discharges where the first operating room procedure occurs after or on the 10th day following admission, and then your OB discharges. PSI 14, your post-op wound dehiscence. These exclude discharges in which the last abdominal wall reclosure procedure occurs on or before the date of the first abdominal pelvic surgery. Your principal diagnosis, of course, if they're coming in the door with it, or if it's POA as a secondary, and the hospital length of stay is less than 2 days, and then OB. And your PSI 15, unrecognized abdominal pelvic accidental puncture or laceration rate includes, of course, your PDX or your secondary as POA. OB discharges and discharges in which the index and or subsequent abdominal pelvic procedure dates are missing. Jeannie, you have a question?
I don't think
Sorry, must have forgotten from before. Sorry.
Okay, no worries. I'll just double check. Okay. All righty. Next slide.
Yeah, is it?
Oh, here it is. Yeah, it's a little delayed. That's all. PSI 17, your birth trauma rate. This is injury to your neonates. So these exclude your preterm infants with a birth weight less than 2,000 grams. Also discharges with osteogenesis imperfecta. PSI 18 is your OB traumas. These are vaginal deliveries with instruments. So excluded, of course, are a principal ICD-10-CM diagnosis code assigned to MDC 15 with newborn other neonates with conditions originating in perinatal period, with an ungroupable DRG, with a missing gender, whether it's the sex, age, quarter, or a year or a principal diagnosis with missing MDC. So you won't be able to include any of that in here. Usually you have most of that stuff though for a DRG assignment. PSI 19 is your OB trauma weight for vaginal delivery without instrument. And this excludes any discharges with instrument assisted delivery. So forceps were used as for delivery or the vacuum. They wouldn't be part of this PSI 19. And your PSI 90 patient safety and adverse events composite, no exclusions. So you have some that have exclusions and some that don't. All right.
Especially the adverse events. So,
right. And you want to keep an eye on, that's why you want to look at your HACs in that respect. And we're going to get into that. Okay. So PSI and CDI. So since PSIs are often depend on accurate coding and documentation, it's up to the CDI specialist to ensure the proper capture of all the patient conditions, right? So some key related considerations, definitely look at your post-op respiratory failure diagnosis and ensuring clear documentation of whether respiratory failure is due to an expected post-op course or a true complication. Peri-op PE DVT, your PSI 12, documenting whether a PE or a DVT was pre-existing versus post-op acquired. AKI is PSI 10, clarifying whether AKI is due to a post-op complication or another underlying condition. Query development for patient safety indicators. And since PSI rely heavily on accurate documentation and coding, query development is crucial for clarifying whether a condition is truly a complication or an expected outcome. And unfortunately, we were talking about the post-op respiratory failure, that if they are on the mechanical vent greater than 96 hours, they will still be plugged in that, popped in that bucket. Okay. Many hospitals do have specific CDI and coding policies regarding clinical validation before PSI reporting, CDI physician queries for POA clarification, and PSI appeals process with payers. And I know at the current company I'm working at, they do have their own quality. They do have their own CDS group for quality reviews for PSIs, because they have a whole slew of query templates in Epic for PSI. So they send, so those CDIs work strictly on the PSIs. All right. This is just a sample query for PSI 03, the pressure ulcer, right? Stage 3 or 4 is documented, but the provider did not state whether it was present on admission or acquired during the hospital stay. So you definitely want to clarify if it's POA. Now, if POA is not documented, it will default to your hospital acquired to a HAC condition, stage 3 or 4. Okay, so that's why you definitely want to clarify the POA status on these, and clarify whether the ulcer was pre-existing, avoiding the PSI assignment or hospital acquired reporting. And then this one is just for a sample query for your PSI 12, your peri-op PE or DVT. It just gives you an example. The scenario, usually you'll see that scenario is listed on the top of the query templates I've seen for the PSIs, because they want to clarify, is it a true post-op complication, or was it present on admission, or was it already pre-existing? So you definitely want to clarify that and document whether prophylaxis was given. It is crucial in risk adjustment, right? So it prevents unnecessary PSI reporting. And that goes back to making sure that, did they have a history of DVT or PE, and they were on anticoagulation, but they were only on it for like 6 months or a year, and then they stopped it. So they could be prone to it, especially if they're going to go through surgery or something. So you definitely want to clarify that to keep it out of that PSI 12 bucket.
And also, like the previous slides, where the doctor will need to document that prophylaxis was done, but it still was not able to prevent, the bleeding. So it would be not put on that PSI bucket.
And then PSI 8 in hospital fall with hip fracture, clarifying timing and cause of fracture. So you definitely want to clarify that. Oh, I think we were done with that one, Christy.
No, the
These are good queries.
yeah. So this is
Oh,
PS.
there's, yeah. Yeah. So you definitely want to clarify those.
Because
And
like,
then this,
go ahead.
and this is just a sample query of the AKI regarding dialysis. You definitely want to clarify that, is it a true post-op complication or is it related to hypovolemia or dehydration? Sometimes patients can develop a hypovolemic shock after surgery. Is it true surgical complication? Maybe not, based on what their chronic comorbidities are too, right? So you really got to take a look at that.
Also, you have to remember that a post-op AKI requiring dialysis. So doesn't mean that the patient has post-op AKI only. It needs to require the dialysis to go to this PSI 10. Okay.
Yep, absolutely. Okay. Yeah, you have to have both for it to go into this bucket.
Mhm.
Okay, and then PSI 11, we've been discussing post-op respiratory failure. So
Yeah.
you definitely want to clarify that.
So these are just example of possible queries. Right? So
But that's saying that it's a PS 11 query, but do we know, was that a scheduled case? Still just clarifying the respiratory.
well, yeah, just clarifying the respiratory failure if it's present, but like you said, if it's a scheduled case, then probably, I mean, it's not included in the, if it's scheduled, then it is included in the bucket. So that's when you have to use this query. But if it's unscheduled, then it doesn't go into this PSI 11 if the patient has postoperative failure. Okay.
Okay. Okay, audits, appeals, and documentation training. So PSI processes with payers. So hospital can appeal PSI penalties, right, if there's strong clinical documentation to support that reported PSI. So you want to make sure that it's clinically expected rather than a true complication. It's related to patient risk factors and not hospital quality issues. And it was misclassified due to coding errors or lack of provider specificity. So since patient PSIs impact hospital quality scores and reimbursements, hospitals benefit from a structured audit, appeal, and training process to ensure accurate reporting. So this is a tailored approach to each. So what you want first, you want PSI audits to be done, right? You want to clarify and identify if there are any errors, identify cases that may be incorrectly flagged, or ensure that only true complications are reported. You want to have PSI appeals in place. You're correcting misclassified cases. So when a PSI is incorrectly assigned, hospitals can appeal to the payers to avoid those penalties. And then 3, you want PSI documentation training for providers and all your CDI teams, as well as your coders. because you want to reduce the PSI rates, right? Hospitals need to educate providers on proper documentation practices, as well as your CDI and your coding team. I think it's very important that coders are involved with that because guess what? They're the ones that code everything, right? They got the final coding in place. So that's why it's really important to do that. So with the PSI audit process, you want to review all POA status for all your conditions. You want to validate all the clinical criteria to confirm that the documentation complication meets your AHRQ PSI definition. You want to assess your risk adjustment factors. You identify comorbidities that justify patient outcomes and prevent unfair penalties for the hospital. And you want to check your provider documentation for specificity. You don't want ambiguous language, can't speak anymore, that lead to incorrect PSI reporting. Like the example down here that we have, was post-op respiratory truly unexpected or was prolonged ventilation planned due to other comorbid conditions. So your CDI role is really implement pre-bill PSI audits to catch errors before reporting to payers. And that's where a lot of hospital organizations do have PSI CDI groups now, just to go through them prior to them being billed out. PSI appeals, correcting misclassified cases. Some common PSI appeal scenarios and strategies. Again, your post-op respiratory failure. Appeal if the patient had pre-existing chronic respiratory failure or had some type of diagnosis of lung disease, and mechanical ventilation was expected due to surgical risk factors. They had thoracic surgery or cardiac surgery. They're not going to be off of vent usually in less than 48 hours. They're going to be on the vent for a little longer than that. And the argument is they had pre-existing COPD or obesity requiring planned ventilation post-op. It's not an unexpected complication. And then your appeal evidence would include your pre-op pulmonary risk documentation and clear statement and provider notes that prolonged ventilation expected due to this condition, their underlying etiology. Another scenario, your PSI 10, your post-op AKI requiring dialysis. You want to appeal if the AKI was due to sepsis, dehydration, or nephrotoxic meds rather than the surgical procedure. The patient has a pre-existing CKD and dialysis was planned. And the argument would be AKI was secondary to sepsis-related hypoperfusion, not a direct surgical complication. And your appeal evidence would be listing the sepsis diagnosis and the timing, as well as, I'm sorry, I didn't finish that one.
Lab showing pre-existing renal dysfunction, right?
No, I was on the AKI. I
Yeah.
didn't finish it.
Oh, this is the AKI now.
Yeah, and lab showing and the provider statement linking the AKI to sepsis. Okay, next.
Okay. See it?
We're still on the
No.
sepsis. You can change it now to the next one.
I
Yeah.
just switched over.
PSI 12.
Yeah, here we go. Okay. PSI 12, your peri-op DVT PE. You want to appeal it if the DVT prophylaxis was given per guideline, but the patient still developed a clot and the patient had increased clotting risk factors, that is cancer or a clotting disorder or any type of clotting risk factors. Your argument is the DVT prophylaxis was administered, but the patient had high thrombotic risk due to a malignancy. Your appeal evidence, prophylaxis orders and administration, and documented risk factors in your H&P. So your CDI role with all of these is work with quality coding and the appeals team to ensure that strong clinical validation for appeals are present. Your key training topics, how to document POA conditions, prevent misclassification, expected versus complication language, avoid unclear phrases like respiratory failure without context. Risk factor documentation. Ensure all comorbidities are captured for risk adjustment. Real world PSI case studies. Teach providers how PSI documentation affects hospital quality scores.
I was just going to say this would be a good education to do like twice a year as a reminder to them.
Right. And you want to have some custom tools for your hospital, right? You want to have a PSI audit checklist, give structured guidelines to help the CDI teams and the coding staff review your high risk PSI cases before submission. Have some sample PSI appeal letters, have pre-written templates to help with payer appeal requirements, that align with them. Customize provider training material, slide decks, quick reference pocket guides, even short videos on PSI documentation pitfalls are always helpful. And then customize your PSI query templates. Make them CDI friendly queries that help clarify complication versus expected outcome. So that way you're ensuring accurate risk adjustment scores and data. Next. Sample PSI audit checklist. You can look at this, confirm PSI trigger criteria met, verify your POA, assess clinical validation, risk adjustment factors. Again, make sure you have your relevant comorbidities and severity of illness documented. Review provider documentation for specificity. You want to make sure that you have the correct terminology within the record, and confirm prophylaxis and preventative measures were followed. They were on DVT prophylaxis prior, and they still develop one. So unfortunately, you can't prevent that sometimes, especially your DVT patients post-op. And then this is just an appeal letter template that you can utilize. I'm sure everybody has them. That just gives you some background. That's all. Just a sample. We like giving information, helpful information to help you make your job easier when it comes to PSIs and appeal letter templates.
Yeah, so at least you could choose here the appeal reason and what are your supporting argument. So just provide a brief yet thorough clinical narrative, and then you also include your supportive documentation like the op report, the progress note. So the insurance company will have all the information to make a decision regarding your appeal.
Right. Okay. And hospitals must monitor, document, improve patient safety to reduce PSI rates. Because why? It affects your HAC reduction program. Low-performing hospitals can lose up to 1% of Medicare reimbursement. It affects your public quality scores. Your Leapfrog Hospital Compare on your CMS website. They'll drop your stars down to 1 or half. Risk adjustment and appeals. You want accurate documentation to help prevent incorrect PSI reporting. And our key CDI role here is ensure that PSIs are correctly documented and do not capture expected clinical scenarios as complications. All right. And I think what do you have on there? The next one is just questions. Yeah.
Mm-hmm.
All right. Any questions?
Good information.
Yes, no, maybe.
Well, if you have any question, just email us and we'll try to clarify some stuff for you.
This
Right.
Timely because of what we're with this new person in our hospital. It reinforces.
Mm-hmm. Yeah. Before I didn't understand PSI, but once I did this, now I know
wow, there's a lot of stuff.
Yeah.
Yeah, Jeannie.
Who does
Yeah,
PSI
just a-
queries for us? That's crazy. I don't know. Sorry.
Just a statement. We had our 3M. You know, it tells you if there's a PSI, right? Well, apparently there was a period of time where the PSIs were not triggering, and so the quality department didn't know to review them. And sorry, forgive me for my rooster in the back. So they weren't reviewing them, and this went on apparently for like maybe 6 months. There were things just not triggering, and I don't know any of the details of it, but it was a fault of the 3M software. And but because we had this long period where the quality department didn't know, they didn't do their reviews, we actually dropped the star, and it's people lost their jobs, and it really hurt the healthcare system. So and I don't know what, I wouldn't know unless the software triggered it for me. I wouldn't know. I don't know to know that. So anyhow, just keeping an eye, and now that I'm learning more, I think maybe I would recognize that, oh, that probably is a PSI. I should go look at that page.
That's right. And before, I mean, in previous hospital I worked, we are asked to submit any PSI we think that could be included, and we submit it to quality, and they make the decision. But sometimes it's so difficult to switch your brain from querying for specific diagnosis to PSI, and it's like, oh, is this PSI or not? I mean, it's just difficult. But I know some facilities wanted the CDI to also look for PSI. So
we have this new thing we have a team that is looking at PSIs. Now, any PSI that is triggered, which it's a little overboard because there's a couple things that trigger, I can't remember the number of the PSI, just because they have end-stage renal disease. PSI. But we have to send a message to my supervisor and this team that is looking at this PSIs on every PSI now going forward, which let me tell you, that really takes up a lot of time.
It is. It takes a lot of time to,
It does, because we're having to email the people, give a scenario, and if you, now really start looking at it, there's several PSIs on chronic conditions, which I understand if they think it's a hospital acquired thing or a complication like that. But like for a PSI triggering from ESRD, I'm like, why do we have to send that? That's ridiculous. There's nothing else involved. Like it's, I don't know. It's just very time consuming. Really slow.
And now there's something new. I don't know when it starts or if it started. I'm under the impression it already started, but we don't have it at our place yet, where it's this failure to rescue thing, where it's not all these separate PIs, but it's sort of this all-encompassing thing. So I don't know any details of it, but it sounded like we're already behind in reviewing for that.
Yeah, because it came out in April. Failure to rescue. Came out with the April updates. Yeah.
Okay.
Yeah. Like I said, I haven't. I was like, that's all new now. They put it all in there now. And I was like, wow, they're adding all this.
When will that class?
Yeah. Whole new ball game. That's for sure. And
started
Patty,
PSI 11, sending them to quality. We've never really had any education on these PSIs. So this is excellent information.
Yeah.
Great, Donna.
Yep.
That's good. I'm glad it's able to help you.
Because like I said before, we're not really into PSI, and then suddenly they give you another task. Look at the PSI. So what is PSI? So it's like, it's a good information, for us CDI to know this.
And this is just hitting the, the surface, because there's so many regulations associated with PSIs, right? With your quality department organizations too. So, And that's
Marie,
the
were you gonna
thing,
ask
you
me a
know, hopefully this will help you just understand a little more about PSIs from a CDI perspective, you know, to definitely open everybody's mind up and brain, you know, here, throw more stuff in your brain as a CDI specialist.
Yeah.
So, Patty, do you work with PSIs too? Since you're a manager, have you,
Sure.
is your CDI team?
Yeah, we do, and we also in the last year we started a monthly meeting with the quality team,
Mm-hmm.
and so we have learned a lot. There's so much more to it than anyone ever thought.
Yeah.
Right.
Yeah. And
Anne,
I think
were you going to ask me a question?
who?
Anne Marie, I thought I heard Anne Marie say my name.
Are you hearing things now?
Apparently.
No, but yeah, I think this is also, you know, where government you know, and other insurance getting information. I mean, like it's being collected, so it's just important right now.
The insurance companies are denying everything. It's
Mhm.
control.
Yeah,
Yeah.
they try to deny everything, so that's why it's a strong clinical indicators put in, or from the documentation. It's a big, you know, a big lift for us or for the CDI department to appeal. So, but sometimes even if you put that there, they're still gonna deny it. So I don't know.
It's like, yeah, well, did you see on the Medicare Advantage programs, they're going to be auditing even more now. There's more
Ah.
scrutiny with them, and it's about time. Yay!
Look at United Healthcare.
Oh yeah, they're definitely fined. Yeah, big time.
They're in big trouble. They're denying conditions on their inpatient stays, but they're bumping up their HCCs. It's like,
Oh, okay.
Oh yeah,
Okay.
yeah, and that's a big piece too. Absolutely.
But
Okay, last but not least, can you guys hang around for about another hour or so? Are you all good
Yes.
to hang?
oh,
Okay.
yeah. Okay, I'm like, hour. Okay.
mhm.
Yeah. Okay. Hospital acquired conditions. Now let's get into HACs.
Slide.
The objectives here, we're going to look at what hospital acquired conditions are, define each one, understand why HACs are an important part of the CDS's reviews, determine POA status when HACs are listed in the medical record documentation, review a couple case studies, and then Q&A. But like I said, stop us during this. Our disclaimers, you know. I'm going to go through those. So let's look at what are hospital-acquired conditions, or HACs. They're complications that a patient develops within the hospital setting. POA indicator, or your present on admission indicator, is listed as N, not present on admission within the claim form. Prevention of HAC diagnoses and procedures are the key here, okay? And it's part of your value-based purchasing program that was developed by CMS. And as a CDI, we can identify and help alleviate possible HACs on the claim form by querying the provider during the concurrent review process. Hospitals can incur a monetary penalty for HACs listed on the claim form. That is, they will not get paid for the HAC diagnosis or procedures that occurred within the hospital setting that were not POA. So the HAC reduction program is what hospitals are ranked based on their total rate of preventable conditions, such as your surgical site infections or your CAUTIs, right? Your catheter-associated UTIs. 25% of hospitals with the highest rate of preventable conditions receive a 1% reduction in your Medicare fee-for-service inpatient payments. Hospitals that are exempt from this program include your critical access hospitals, your rehab facilities, rehab hospitals, long-term care hospitals, your psych hospitals and units, as well as some children hospitals, your cancer hospitals, your VA, any short-term acute care hospitals within the U.S. territories as well. The HAC reduction program is comprised of our CMS PSI 90. We brought that up in the other PSI presentation, as well as the hospital-acquired infections that the CDC has listed for us. Your HAIs also include your CLAPSIs, your CAUDIs, any colon abdominal hysterectomy surgical site infections, as well as your MRSA bacteremia and your C. diff infections. Now, the next slide is just a listing of all the HACs that we have that we look at in the hospital setting. Okay. The HAC general reporting guidelines. POA indicator is mandatory for all claims involving inpatient admissions to general acute care facilities as well as other facilities. Your POA is defined as present at the time the order for inpatient admission occurs. Conditions developed during an outpatient encounter, including your ED observation or outpatient surgery, are also considered POA status. When the patient was flipped, say they flipped from observation status to inpatient status, the doctor writes the order. POA for all those diagnoses would be listed as, yes, they're present on admission. And a POA indicator must be assigned to all your principal diagnosis as well as your secondary diagnoses. And it's based on the official guidelines for coding and reporting as defined in Section 2. And any external cause of injury codes must also be listed. CMS does not require a POA indicator for an external cause of injury code unless it is being reported as an other diagnosis. So when you have your external codes, like your, what is it? Like if you had a motor vehicle crash and it was a accident, a Y code or a Z code, usually they're listed as an E on the 3M encoder as external code, external care code, okay, or cause of injury code. So you wouldn't see those listed as a Y or N. There are issues related to inconsistent, missing, conflicting, or unclear documentation must be resolved by the provider. That's where we send our queries. And if a condition would not be coded and reported based on the UHDDS definitions and current official coding guidelines, then the POA indicator would not be reported as well. And that's directly from the CMS website, and I gave you the link there. So some estimated costs associated with your HACs. This is what some of the adverse drug events they've lost. Some hospitals have lost 5,700 estimated costs, 95% of the HAC costs, because they lost that as revenue for the hospital for that patient admission. And you can see there's quite a few. There were studies done, 2 studies for the ADEs. Catheter associated has 6 and your CLAPSIs had 7. That's okay. They can go through, you guys can go through it, and it just gives you an idea, estimated costs. Now, some of the HAC additions that they added in, HAC code I2603 is an MCC. This is where your cement embolism of pulmonary artery with acute cor pulmonale. And then your other one, I2604, is fat embolism with acute pulmonary, fat embolism of pulmonary artery with acute cor pulmonary artery. And then your other HAC codes listed are without your acute pulmonary cor pulmonale. So you have cement embolism and fat embolism listed within the HAC additions. Now the procedure HACs, these are fusions of thoracolumbar vertebral joint using facet joint fusion device, paired titanium cages, open approach. These are all new technology procedure codes. So the neurosurgeons or the orthopedics who are doing your spine fusions, spinal fusions, check to see if they are using these. because they're gonna look at these, and if there's a problem with them, it's gonna be reported as a HAC upon patient's discharge. Okay, descriptions. When it comes to HAC 01, the foreign body retained after surgery, these are your T codes. These are your complication codes, and it'll tell you for the first code, it's a CC capture, and it won't count as a CC, it counts as a complication. And these adhesions due to foreign body accidentally left in body following infusion or transfusion, initial encounter. And then adhesions due to foreign body accidentally left in body following other procedure, initial encounter. And then, of course, an obstruction due to foreign body accidentally left in body following other procedure, initial encounter. However, please note, if the foreign body is removed during the same hospitalization, it does not count as a HAC on the claim form. So it's removed, it's not a HAC within the same episode of care. HAC 02 is your air embolism, and your T code for this one is air embolism following infusion, transfusion, and therapeutic injection, initial encounter. And this would be listed as a HAC on the claim forms for air embolisms that follow any infusion, transfusion, or therapeutic injection. So if a patient develops an air embolism, guess what? You got a HAC following any of these procedures. HAC, the next HAC is, I think, blood incompatibility 03. These are some of the codes listed. Now, reactions with ABO incompatibility reaction due to transfusion of blood or blood products unspecified. These are all initial encounters. ABO incompatibility with hemolytic transfusion reaction or other ABO incompatibility reaction due to transfusion of blood or blood products. So please note, reactions include hemolytic transfusion, whether acute or delayed, and other incompatibility reaction. So it doesn't matter whether it's an acute hemolytic reaction or it's delayed and the patient doesn't develop that reaction until, say, next day or a day later, it's still going to be listed as a HAC under that blood incompatibility. HAC 4, your stage 3 and stage 4 pressure ulcers or pressure injuries that everybody uses now, the verbiage. It's mainly your pressure ulcers of left upper back, stage 4, right upper back, stage 3, and then your right ankles 3 or 4. This is just a snippet of the listing of all the HACs that are listed within the HAC file. I can forward you the zip folder if you'd all like. Just let me know at the end. And the sites that we look for are the elbows, buttocks, sacral region, hips, ankles, heels, and other sites. HAC 05 are falls and traumas. And of course, this is just, again, a snippet because there were so many HAC diagnoses to add. Also included under trauma diagnosis are your crushing injuries, burns, corrosion, frostbite, and there was something else after that. HAC 6, asphyxiation. Thank you. So HAC 6 is your catheter-associated infection. So make sure that it's an indwelling urethral catheter or another urinary catheter. It could be a cystostomy. Cystostomy catheter or your suprapubic. There are other additional diagnoses that would be listed on the claim form with the above HAC, such as your acute pyelo or candidal cystitis or pyonephrosis. HAC 7. Your vascular catheter-associated infections. These are your bloodstream infections with a CV catheter. Can we take a quick break? Sure.
Okay.
Local infection, other, I'll come back to this. So let's take 5 minutes.
Okay.
All right.
Greg? Jill? Okay,
Oh, no, because something's wrong with the computer, so with the program. So I have to have my audio on. So check with you.
So how much longer is gonna have?
Oh, pretty soon, probably till 2:30.
Okay. I walk in there, it says 94.
Oh, yeah. Ooh.
Why do you put this in here? Comments? Small one?
Yeah.
Oh, because they're both around you.
Yeah.
Small before. So, very sweet, what's that? Yeah, they see it with the sweets. Good. 94, man. Man, oh, man. So let me know when you're done, okay?
Mm-hmm.
Okay. Oh, okay, Patty. Sorry she had to go. Debbie, are you back?
I'm here. I didn't leave.
Okay. All right. What time's your appointment?
Me?
Yeah, don't you have your appointment? You're here?
Oh, no, next week. I changed it to next week.
Oh, okay. Okay.
Yeah. No.
All right. Let's see. Donna, you back?
I'm back.
Okay. And Jeannie? Not yet. Okay.
So I emailed you guys the evaluation and test. But disregard the CEU that will be printed. I'll print another one and send it to you.
Yeah. We'll give you another hour.
Hmm?
Okay, here. Okay. All right. Let's get rolling again then. Okay, so HAC 7 vascular catheter associated infections. This is your CLAPSIs, your bloodstream infection due to central venous catheter initial encounter, or local infection due to central venous catheter initial, other infection due to a CVC, and then unspecified infection due to a CVC catheter initial encounter. So any of the above diagnoses will be listed as a HAC on the claim form. Unfortunately, you can't get around these unless it's the principal diagnosis. HAC 08, your surgical site infection, mediastinitis after bypass. So they clarified the surgical site infections now. So they're associating it with a particular procedure. So if mediastinitis is documented post-procedure, this will be listed as a HAC on the claim form as other diseases of mediastinum not elsewhere classified. So that code will be listed as it have an H within your encoder.
What if that infection is present on admission?
The infection is present on admission, then it doesn't count as a HAC.
Okay.
Okay. It's not, it's POA status. That's why POA is very important for any of the HAC diagnoses. Okay. HAC 09, the manifestations of poor glycemic control. These are your E codes with diabetes mellitus, and it's due to underlying condition with the NKAHC, or your diabetes mellitus with ketoacidosis without coma, or your drug or chemical induced diabetes, DKA without coma, and then other specified diabetes with ketoacidosis or a DKA. So if a patient develops DKA post-procedure, you're going to have a HAC on your hands because they should have been monitoring that diagnosis. These are just a snippet. Like I said, if you know, there are so many other different diagnoses with diabetes associated that it's going to be listed. Okay. HAC 10 is your DVT pulmonary embolism with total knee replacement. So if whether it is any type of PE, whether it's saddle or subsegmental or DVT that develops post-procedure. Yeah, you can go back one slide, Christy.
Sorry.
Okay, if it develops post-procedure, it will be listed as a HAC on the claim form. Unfortunately, you can't, the only way you can combat this is if they have a history of PE or DVT, and then you send an appeal letter to the provider, okay, to the insurance to indicate, no, you know, unfortunately, we did all this, like the PSI category, the diagnosis with DVT PE, and they have a prior history or something, then you hopefully you can appeal and get that off your HAC list. All right. HAC 11 is surgical site infection for bariatric surgery. Now, besides the procedures listed above, your post-procedural retroperitoneal abscess. You're still on HAC 8 slide? Okay, Jeannie, I don't know. Maybe log out again and log back in. Or use,
Are the others seeing the right one?
are you guys on HAC 11 slide?
I'm on HAC 11.
How about Donna? How about you?
Oh, weird. Okay, I'll try again. Weird.
Okay. Sorry, Janie. So when it comes to your HAC 11, your post-procedural retroperitoneal abscess infections following the procedure, whether it's superficial, deep, or organ-related with the PDX of morbidity, morbid obesity, it'll be listed on the claim form as a HAC. So you definitely want to make sure you don't get any type of infection post bariatric surgery. That's for sure, because it will be listed as a HAC. Okay, HAC 13.
12. 12. HAC 12.
12, I'm sorry. Yeah, HAC 12. I'm ahead of the game here. Surgical site infection, your certain orthopedic procedures for spine, shoulder, and elbow. So these are some of the procedure codes you may see. Like I said, there are so many of them within all these items. All these HAC listings is too numerous to count, that's for sure. All right, Jeannie, you're caught up now. Okay. So again, going back to your post-procedural retroperitoneal abscess or infections following the procedure, no matter what depth it is, it will be listed as a HAC on the claim form. 13 is your SS surgical site infections following cardiac implantable electronic device procedures. This is where you have an insertion of an intracardiac pacemaker into a coronary vein percutaneous approach. It could be an insertion of a defibrillator lead into the left atrium percutaneous approach, even an insertion of a pacemaker single chamber into chest, subcutaneous tissue and fascia open, or revision of a cardiac rhythm related device in trunk, subcutaneous tissue and fascia. It all boils down to whether it's superficial, deep, organ related, you have an abscess, you have an infection, it's going to be listed as a HAC on the claim form. HAC 14 is your iatrogenic pneumothorax with venous catheterization. Now they changed this one. They associated it with a central venous catheter that's inserted. So, you know, in critical care, when they're in ICU and they're coding on you, they're going to throw in try to get some big, large bore needles in IVs, right? And they're going to also try to throw in a CVC. And if an iatrogenic pneumothorax occurs with it, this will be listed as a HAC on the claim form because it's during any venous catheterization procedure. So they're associating it with one specific item, which is a good thing. And it's not all these iatrogenic pneumothorax is related to all procedures. The importance of HACs to CDI, rationale. The review of medical records by CDS specialists encompasses all diagnoses that accurately represent the patient's condition during the hospital stay, ensuring that each diagnosis is as specific as possible, including hospital-acquired conditions. Consider the review process as a risk-based approach that aligns with value-based purchasing program established by CMS, and your risk adjustment has emerged as a key focus for CMS, private insurers, healthcare organizations, as well as individual practitioners. This focus results in risk adjustment payments for hospitals and providers, gradually moving away from the traditional fee-for-service payment structure. So more than 78% of CDI departments evaluate POA status and perform mortality reviews using the observed expected outcomes ratio for their assessments, or the OE outcomes. And Jeannie, I think you do that's what you do, correct?
I do mortalities. Yeah.
Yeah, so that's a big piece of it. So why are HACs so important to CDI? It's about quality reporting and public accountability, right? CMS tracks all the hospital-acquired conditions as part of its evaluation for hospital performance. That is the HAC reduction program. They're looking at inadequate documentation of conditions present on admission that may result in misleading quality metrics, which do not accurately reflect the hospital standard of care. And this is where CDIs play a crucial role in determining whether a condition existed at admission or developed during the hospital stay, thereby helping the hospital avert unwarranted penalties with a HAC diagnosis on that claim form. There's also financial implications and reimbursement. So under CMS guidelines, specific HACs do not qualify for increased DRG payments if they are not classified as POA, regardless of whether they involve complications or comorbidities. And a thorough CDI review guarantees the proper sequencing and POA status, safeguarding hospitals against revenue loss and compliance risk. A couple other pieces to the pie why HACs are so important for CDI groups is adherence to regulations and risk management. Insufficient documentation and coding of HACs may lead to audits, heightened compliance scrutiny, and even accusations of fraud and abuse. So as a CDI specialists are vital in ensuring that medical records are accurately and defensively documented, which is critical for successfully navigating payer audits and reviews. And last but not least, impact on patient safety indicators or PSI and risk adjustment. Many HACs are linked to the AHRQ patient safety indicators that we went through on our previous presentation. And this will result in accurately classifying condition as HACs can result in misleading PCI outcomes. So guess what? If we code a HAC, which isn't a real HAC, then it goes into the PSI bucket. Now we got a dual penalty coming. Okay. So comprehensive CDI rule reviews can support PSI appeals by clarifying clinical evidence. For example, verifying that an infection is not truly catheter associated or that a pressure ulcer existed at the time of admission. That's why it's so important to clarify POA status for your HACs diagnoses. Educational role and provider engagement is key. CDI specialists play a crucial role in informing healthcare providers about the importance of HACs and emphasize the necessity for precise and timely documentation of all HACs, including most importantly, your pressure injuries or ulcers, your CAUTIs, and any falls that occur. They help providers comprehend how accurate documentation influences both the patient safety initiatives and the institution's standing with when it comes to quality documentation. And last but not least, your clinical accuracy and care continuity. Accurate identification of HACs is vital for effective clinical profiling and maintaining continuity of care. And for instance, differentiating between community-acquired and hospital-acquired infections can significantly influence strategies for antibiotic stewardship and infection control. In summary, HACs are significant for CDI as they impact public reporting and quality metrics, as we know, hospital reimbursement and DRG categorization, compliance with legal and regulatory standards, accuracy of PSI and related appeals, documentation practices of physicians, comprehensive patient safety efforts. CDI specialists again play a crucial role in minimizing financial penalties, enhancing data precision, and fostering high quality patient care. So what do you do if you see a HAC? from a CDI perspective, you should clarify if a diagnosis or condition was POA or not POA via query opportunities. It is up to the healthcare provider to make that determination on all diagnoses, including HACs. Keep in mind that there are numerous risk adjustment models available to hospitals and providers, as well as many quality and patient outcome benchmarking programs that track HACs within the inpatient setting. And this is just CMS's quality measures, and it's all overlapping. As you can see, there's hospital ranking models, PEPR reports, your private benchmarking solutions, risk adjustment payment models, as well as CMS's quality measure programs. And in the middle of the overlapping focus includes your HACs. So your overlapping focus areas include your mortality rates, your readmission rates, your HACs, stroke, sepsis, pneumonia, everything that they're looking at from a quality perspective. And I just gives you a little snippet of what the private benchmarking solutions are. Like Vizient is in here and Leapfrog. And then of course, your RA, your risk adjustment is your Medicare Advantage and your Affordable Care Act are in here in Medicaid. Okay. Which gives you an idea. That's from the ACDIS website. All right. POA status. So POA indicators, Y is present on admission, N is not present on admission, U is insufficient documentation to determine if the condition was present on admission, and W is clinically undetermined. So when you're working with providers think they only have a yes or no response when querying for POA status. Keep in mind that clinically unable to determine is also an option for them, and it's usually listed. It should be listed on that POA template. And then the claim form would list W as clinically undetermined for a particular diagnosis if the provider cannot deem it as yes, present on admission, or no, not present on admission. And you will see W listed in the final coding for those patients. Okay, case studies.
Okay, sorry. 78-year-old female presented in ER with shortness of breath, rhonchi, and cough. She resides at a SNF where she was running a temperature of 102.4, current vital signs temp of 101.8, pulse of 115, respiratory of 24, and BP of 101/56 with saturation of 90% on room air. Past medical history includes COPD, hypertension, hyperlipidemia, and hypothyroidism. ER clinical impression, pneumonia likely bacterial based on fever, shortness of breath, leukocytosis of 18.4, lactic acid of 2.5, and chest x-rays positive for consolidation right upper lobe, initiated IV azithromycin, IV cefepime, to be admitted under medical hospitalist team. Attending provider assessment is planned, presented with SOB, cough, and temperature, likely related to gram-negative pneumonia. Continue IV cefepime and IV azithromycin. Recheck chest x-ray in 2 days. Recheck CBC tomorrow and lactic acid. On hospital day number 2, attending provider notes rapid response called for hypotension. Received 2 liters of normal saline without effect. To be transferred to ICU for vasopressor drip. BP is hovering around 79/48 to 85/52. Critical care consult impression, septic shock secondary to gram-negative pneumonia, originally admitted to telemetry unit by medical hospitalist stream. Rapid response called today due to ongoing hypotension, transferred to ICU and initiated liver drip. Hospital day number 4. Critical care progress note indicates hypotension resolve of liver drip. Continue gentle IV hydration. Patient alert and responding to simple commands and questions. Daughter at bedside. Does indicate patient has mild memory impairment from previous stroke. No other deficits noted. Blood cultures positive for Klebsiella. Continue IV cefepime, IV azithromycin for 7 days. Stable to be transferred out of ICU to step-down unit. Medical hospital is notified. So is the primary diagnosis.
Sepsis.
Did we have to, I'm so sorry, I missed part of the beginning. It sounded like we had a gram-negative pneumonia and then maybe sepsis came in later, but otherwise, if sepsis was POA, then definitely sepsis would be our PDX.
Okay. So right now, it looks like on the second day of hospitalization, so it's critical care consult says septic shock, right? But in ER and excuse me, attending physician documented gram-negative pneumonia. So you're saying that sepsis is the primary diagnosis, right?
Did they?
Well, you had the labs that supported present on admission.
Yeah. So I mean, in my opinion, I would right now, it would be pneumonia gram-negative. Then probably I'll query if sepsis is, present on admission.
Yeah.
Right. So, but because all the clinical indicators are geared toward, looks like the patient has sepsis. Lactic acid is elevated at 2.5. And then on the second day, the blood pressure dropped to, 79/48 and 85/52. So, I don't know. For me, I would definitely
query to admission. In our opinion.
Yes. So, and then, so we have the secondary diagnosis. It has COPD, but it doesn't say whether the patient is on any O2 supplement at home. So we could find it out also, like in case manager or social services note. Sometimes they will note what the patient has equipment at home, so we could find out whether the patient is having chronic respiratory failure. Although it doesn't say here whether the patient was given oxygen supplement, just the hypotension, right?
Yeah.
And
we have the gram-negative pneumonia, so we're good on that.
That's right.
Wait. Hold on. Where did I think I saw that? Okay, go to the next slide. If we get combining with the POA query, is we want to get that sepsis to a gram-negative sepsis because the blood culture is positive for Klebsiella.
Right. Yes. So you could query that to be more specific, like sepsis due to Klebsiella with positive blood culture, right?
Yeah.
And there's no encephalopathy. It's just the shock.
That's it.
Mm-hmm.
Yeah.
So, and unfortunately, even if we do have sepsis as our PDX and we have a secondary diagnosis of pneumonia, without having severe sepsis, POA, yes, we get a ding as a pneumonia. They're at it's not a mortality yet, but of course that's where I'm thinking. But even patients who don't die, they go into this pneumonia bucket unless you have severe sepsis POA. But even if we had severe sepsis POA, which we probably do, because septic shock is not POA, then we lose that code of the POA, yes, and we only have the severe sepsis with septic shock POA, no, and we still are in a pneumonia bucket.
That's right. Yeah. That's why, let's see here. Here we go. So this is a sample query for POA for septic shock. The clinical indicators would be hospital 2, attending progress note. The doctor indicates rapid response called for hypotension, and the treatment with the normal saline and the vasodrip, and as well as the blood pressure. So I think it's safer to ask whether it's present on admission, since it was documented in hospital day number 2, and the blood culture.
Did we have indicators for septic shock POAS? I didn't see that.
No, it doesn't. It is on hospital day number 2. The blood pressure is hovering about 100/56 on admission.
It looks like
that
that query was worded was septic shock POA. Clarify a septic shock was present on admission. Well, septic shock was not. I think the question should be, is sepsis present on admission?
On admission.
Yeah. It should be sepsis present on admission.
Yeah,
Because
severe sepsis was severe sepsis with septic shock, and I would ask that question if it was POA.
But there's no indicators for septic shock POA. You didn't have a low enough blood pressure on admission. Your lactic acid isn't greater than 4. You weren't on pressors. You didn't have altered mental status. There's nothing to indicate that septic shock was present on admission. That I would say
Should be clarified. That should be changed. You're correct, Jeannie.
it should be present on admission is only sepsis.
Sepsis with
Yeah.
severe sepsis associated with
Because-
pneumonia.
Yes.
Negative pneumonia.
Because if the patient on the second day, the doctor clearly documented septic shock, right? So the shock is the acute organ dysfunction. So it also goes to the same DRG, severe sepsis with acute organ dysfunction, without querying whether the shock is the acute organ dysfunction. If I remember it right, it defaults.
Exactly.
That's
severe
kind of
sepsis.
a tricky case because you get your sepsis POA and then your severe sepsis with septic shock, not POA. That's
why you want to clarify POA status with everything, with the provider.
Yeah. But correct me if I'm wrong, if the patient has sepsis and then the patient has septic shock later, doesn't it default to severe sepsis with acute organ dysfunction?
That's how
It
I
does.
thought.
it is
That's how I
severe
was
sepsis. It's severe sepsis with septic shock, but because it's a combo code, your initial, so it doesn't even do you any good. We definitely want to query, is sepsis POA, but it doesn't do you any good to ask, was that severe sepsis POA?
No.
Because
Mhm.
severe, because that combo
Yeah,
code, you
right.
have to take that away.
That's right.
Correct.
We
Septic
just-
shock is your severe sepsis with
Yeah, I feel
organ
like
dysfunction.
we go through this conversation at my workplace probably every 6 months, and even the other girl who does mortality reviews, she's like, that doesn't make any sense. It doesn't. I'm like, how many times can I explain it to you? And I'm just going to ask the coding people. I'm like, good for you. Just ask them. But he ain't going to tell you nothing different, honey, because this is just how it is.
That's right. So yeah, it doesn't make any difference to ask whether it's severe sepsis with acute or just
We just
ask
want sepsis as
for
POA.
sepsis as POA. Then if the shock happens later, it will just default to severe sepsis. So yeah, so we need to query the sepsis POA just to be on the safe side, because I think I asked my manager about patient having, because the blood culture doesn't come back probably 2 to 3 days later. So, but it has the indicators for sepsis. So her opinion is that, we have to wait for the lab to come back or more information. And for example, on the 3rd day, it's positive, then we could presume that it is sepsis present on admission. So
But you have your after study as well. So
yeah,
you
that's right. Yeah,
48
after
hours to
study.
6 hours
Mhm.
workup.
But-
So
Mhm. Yeah, so that's why it's up to the policy of your facility, but to be safe, I think we need to ask sepsis for POA.
Very good.
Yeah.
Good catch, Jean.
So these are just the indicators for pneumonia, which we discussed already a while ago. For query opportunities, if it's documented, so we could query pneumonia. But on this case, it's been, documented the patient has gram negative. So, and this case study number 2, 48-year-old male directly admitted to the hospital for elective bariatric surgery. His current BMI is 52.4, has history of hypertension, prior history of right lower extremity DVT on Eliquis, and morbid obesity due to excess calories. Hospital day number 1, patient undergoes sleeve gastrectomy without initial complication. Hospital number 2, patient experiences dizziness, hypotension, tachycardia. Workup reveals acute drop in HNH from pre-op testing of 15.6 35.6 to current testing of 8.6, 22.1. CTAP reveals hyperdense attenuation, suspicious for hemorrhage. Patient urgently taken back to OR on hospital day number 2. Surgeon findings indicate retroperitoneal hematoma noted in the abdominal muscle, status post-evacuation. No other signs of bleeding noted from any other blood vessels or anastomosis. Hospital day number 3, patient feels okay, not as dizzy as I was yesterday. Discussed the complication that occurred with the retroperitoneal hematoma. Patient confirmed that he did not take his Eliquis 5 days prior to surgery. We have not restarted yet due to hemorrhage. HNH stabilized at 10.3 and 29.8. Post 2 units of RBC transfusion given. We'll recheck HNH tomorrow. So what is your primary diagnosis?
The morbid obesity, I would imagine.
Yes, because that's what the patient is having the surgery for, right? The sleeve gastrectomy. So
we take that to a class 3 obesity diagnosis, right? Because now coding is getting away from the morbid obesity and wants the obesity coded in classes.
Yeah, that's right. That's the new. I think I saw that.
I got a new classification.
New thing.
Classification now, not just morbid obesity.
Right.
But
Yeah,
that would be,
the charts.
yeah, so that would be our primary diagnosis, right? So, any query opportunities here?
I was thinking we would need to query for acute blood loss anemia, but I do think, doesn't the word hemorrhage, would that give us the, without having a book in front of me, will that hemorrhage give us the a post-op hemorrhage?
Yes. We could ask for acute blood loss anemia, right?
Yeah, I would clarify that.
I would clarify that.
Then go for hemorrhagic shock, but I'd go for obla with a query.
Yeah, especially the patient was given 2 units of RBC.
Yeah.
And they're more or less monitoring the HNH. So I would ask for acute blood loss anemia, right? And then
code in there now. Great.
Do you think this qualifies for PSI? I mean, yeah.
Oh yeah, it'll be a shock. That PSI for a shock.
We don't.
Well, we're going to get that diagnosis of shock after we query. We're going to get a diagnosis. Someone said yes, and then it will be a PSI.
But we'll have the hematoma too as a POA no, so that I think that triggers a PSI if I'm not mistaken.
HAC.
I can't remember them all, so don't quote me.
Yeah. It will.
Too much in my head.
You're right.
Yes, right. So, what do you call this? The patient has been taking Eliquis due to DVT, right? So, the patient stopped the Eliquis 5 days prior to surgery. So there was a prophylaxis, right? If I'm about the PSI.
Yeah. Hopefully, you would think it would be out of his system, but
right. They said they stopped it. So if they stopped it when the doc said, obviously, if we found out, oh, whoops, I forgot to stop it, then you would want to query for that cause effect of, oh, was this bleed partially due to the Eliquis? And then you would get out of that PSI, I believe, but I don't think there's indicators for that if they were already stopped, right?
We need to see the coag panel too. What's his INR and his PT? Maybe 5 days wasn't enough for him. We
Him
don't
to
have
stop,
that
yeah.
information.
Because
He should be out of his system, but
as far as I could remember, if the prophylaxis was done prior to surgery, then it should not be on that bucket for hematoma. I
Shouldn't
need
go into that.
to hematoma. So it's clearly documented has not taken the Eliquis. So I don't think it should go to that bucket. But I have to
If
remember.
it does and say that, you know, you want to appeal it, then you have the documentation to prove
Right.
it, right?
that's it. I'm like,
Okay.
there's a thing around that, and
For PSIs.
For PSI, yes.
Okay. Yeah.
But it could. I think hematoma, intraperitoneal hematoma, is a CC. So
yeah, I think so.
we have a CC here for our DRG, and we have a possible query for acute blood loss anemia, right? Is it gonna be a post-op complication?
Yeah. It'll be
Yeah.
listed as a hack.
Yeah, it's a
Yeah,
post-op
'cause his
complication.
pre-op lab was 15.6 on his hemoglobin,
Mhm.
down to 8.6. So
The retroperitoneal hematoma occurred post-op, so it'll be listed
yeah,
as a
it'd be
complication.
not. Yeah, it should be net.
So it would be listed as a hack on the claim form for this particular case.
That's
You
right.
can fight the PSI one, but hack, you can't fight it because it's documented as a complication by the provider.
So, okay, I think that's about it. Dizziness probably because of the drop in H&H. And
Especially you have a back to the OR. That triggers.
urgently taken back to OR. Yeah.
That's trigger.
So
We're going to have a hack for this case, unfortunately.
yeah. Okay, so this is just a sample query for acute blood loss anemia, right? So you have your indicators and you have choices for the doctors to choose.
Okay. Very
And
good.
this is a sample query for the complication of procedure. And you give the doctor the choice. Is it associated with the procedure? Is not associated with the procedure? I mean, it's
There's no other way. I think this query doesn't make sense. There's no other way this person could have had a retroperitoneal hemorrhage except for the procedure.
yeah, and also the doctor said there's no other anastomosis place where the bleeding could be found. So
On the case study, yeah.
Yeah.
It's just giving you an idea of how to create a query for the
Or if it wasn't clear, if there was a question on it, this could be.
yeah, if there was a question, that's all. We're
And-
just sharing this sample query for you guys. That's all.
So it doesn't need to be the retroperitoneal. I mean, does not need to be associated with the case, but this is just a sample. If you wanna,
These are some good queries. I'm definitely going to be utilizing the way it's formatted.
Verbiage to give you some information. That's
Yeah.
all. Because he wrote it in his note, it was a complication in the progress note.
Yeah, if he wrote it like that, I wouldn't query.
So complication. Okay, go ahead.
So your complication of care notes can be listed as a principal diagnosis or as a secondary. It depends on the circumstance of admission. If the patient is admitted for treatment of the complication, then the complication diagnosis is listed as your PDX, which is usually a T code, followed by a secondary code if the complication code is not specific enough to describe the complication. For example, a 58-year-old female admitted to the hospital for abdominal wound dehiscence following a hysterectomy 3 days prior to admission. The wound dehiscence, which is the T81321A, will be listed as the PDX. Okay, in that instance. Okay. Sometimes you may have other complication associated with procedure. And if you don't know what the other complication is, it may be listed as another diagnosis. Say it's not a wound dehiscence or it's not a surgical site infection. It may be a hematoma or maybe something else. Then you would list that as a secondary diagnosis, if that makes sense. Because you may have two codes if that complication code doesn't specify enough to describe the complication. Does that make sense?
Or you could query it, right?
Or you query for it, right?
Mm-hmm.
Okay.
If it's not clear. Okay. Right. So this is case study. 93-year-old female presented to ER with chief complaint of cough, congestion, past medical history of chronic diastolic heart failure, CKD3B, stage 3 pressure ulcer to the coccyx. Attending providers assessment plan indicates admit to telemetry medical surgical unit for RSV pneumonia, continue broad spectrum IV antibiotics, follow up sputum culture result, CBC and chest x-ray, chronic diastolic heart failure, not in acute decompensation, CKD stage 3B, renally dosed medication, stage 3 pressure, injury to coccyx, wound care consult. Wound care consult notes the following: stage 4 pressure ulcer to coccyx, wound care orders added into EPIC, continue wound care protocol. So what's your PDX?
Pneumonia.
Pneumonia, right? Yeah. The chief complaint is cough and congestion, and the attending doctor says RSV pneumonia, right? So what would be your secondary diagnosis?
Diastolic heart failure, CKD3B.
Uh-huh.
Well, you're going to have to query because now you got a difference in documentation of that ulcer.
Very good. Yeah, because he's saying or she's saying stage 3. Well, the wound care nurse said stage 4, right? So you want to clarify that, which the stage is. So that would be your what do you call this, query opportunity there because of conflicting documentation. Okay, what else?
Our CC would be the chronic diastolic CHF.
Hmm.
And then we have our combo code with the kidney disease.
KD, yes.
You did say continue broad spectrum IV antibiotics, but this is an RSV pneumonia. So do we have a query opportunity for a superimposed bacterial pneumonia?
That's right. Very good. So you follow up the sputum culture, right? Because right now he's just saying RSV, but there's no sputum culture yet. And then there's a broad IV antibiotics. So you want to follow up with the sputum culture. And then probably depending on the result, you could have a query opportunity there.
It may have a bacterial pneumonia with the viral pneumonia, RSV pneumonia.
Yeah, it could be.
Very good.
And the pressure ulcer, I mean, it was stated on admission. So we don't need to query the present on admission on that one. And yep, CKD is okay. So we're good. Any query opportunities still?
Just depending upon the sputum culture and what antibiotics they're on.
That's right. Yeah.
For a gram-negative pneumonia as well, or a bacterial.
Or bacterial, yeah. So we need to follow up the sputum culture. Okie doke. So this is just a sample for pressure ulcer confirmation, right? So if it's stage 3 or stage 4, and you give the doctor the, what do you call this, the choices. Okay. So
let me ask Anne-Marie a question real quick, just because I'm not sure how like Jeannie's and Dawn, I think the other gal's hospital works. But like when we have a wound care note, and if the doctor signs the wound care note, then we can code what wound care documented. But if they documented stage 3, would you still clarify?
Where I'm at, I would pray for the doctor not to give me a stage because the doctor's never going to be right. I would prefer that he just say there is a pressure ulcer on the coccyx, and then whatever the wound care nurse says is going to be what we code. So, but because the doctor gave a stage and wound care said something different, and in the example, yeah, you'd have to query, but in the example, it didn't say what date the wound care nurse saw the patient on. So if they didn't see the patient until a week, or did it progress? That's super important to know. But chances are, we just need to query
difference in doctor versus nurses. Which, like you said, doctors are never right on that.
They're never right. They're never good. And they don't need to be. We just try to teach them to, say where it is.
That's right.
Type and type. Right.
And our wound nurses have a template it's very clear of, was this present on admission? Yes or no? What stage, all that, and then we're able to take that, and so our query template actually says, here's what the wound care nurse says. Do you agree with the wound care nurse? Do you not agree with the wound care nurse? And of course they're going to agree with the wound care nurse.
Yeah. And also,
may say no, disagree.
and like Jean was saying, we don't know when the wound care nurse saw the patient. So, for example, you have not a template, but a part of medical record of the wound care consult, and the doctor signs it. But if the doctor signs it, what do you call this? When the wound care nurse saw the patient, so that supersedes the previous documentation. The problem will be if he signs that, and then the following progress note, it goes back to what he wrote because they
copy and paste it.
And that's a
problem. Bring it forward the new
problem.
So I think we should trigger a query because he himself has a conflicting diagnosis. So
he's the one that created the conflicting documentation.
Yeah. So any more questions?
No, I think we're good.
Kiddo. So open your email for that
Yes.
evaluation. And then let's see here.
Oh, goodness.
Thank you. Excellent presentation.
Oh, you're welcome.
I always love their presentation.
And thanks for staying over. I think we'll add. What were we going to add? It was 4. We were going to do it up to 6 or
6.
something, Chrissy?
Yeah, 6 hours.
Yeah, 6. Yeah.
Give you 6
We're all
hours.
going to get 60 EUs.
Oh, wonderful. Thank you so much.
Yeah. Okay, let me just
calculated everything.
Well, it also questions, which helps a lot to understand things too.
Yeah. Okay, so you finished the eval? Are we going to?
We have to do the eval first? Hold on.
Yeah.
Let me get that done for us.
Oh, mine started right off with the test. So I'm doing the test.
There's a separate email for the eval.
Oh, for Pete's sake. Whoopsie. Hold on.
Because I just got it too.
Gosh, I wonder.
Donna, did you get the eval too?
I haven't looked yet. Sorry.
Okay.
Oh, okay. No worries. Take your time. Yeah, the eval is a big piece for us for our provider license.
Yeah, no, it opens up at the PSI HAC. So it's a separate email, huh?
You didn't get the eval?
Yeah, it's
Apparently
coming
not.
from Trust Pilot is who sends the eval. So look for
Okay,
Trust
maybe it
Pilot.
went to my junk email. Yeah, because I got one eval and test, but
Okay, so why don't we do this? We could do the test now, and then I'll send you the eval. If you could
Okay,
just,
yeah, please.
so,
I don't see an eval. No.
okay.
Yeah, I only have the original one you sent.
Donna, okay. All right, yeah, let's go through the test then, Christine. And then you guys can do the eval when we're done. And then it should pop up for you.
Okay, so let me do this. Respiratory share screen Windows.
Chloe is trying to tell me that she wants her outdoor time.
Chloe, you're Katie?
Yeah, because she's not allowed on the patio without me out there. And she's like,
Oh.
I've been on the patio the whole time.
I need my computer, so I can't do that. But yeah, she's like, come on, Mom.
I use my laptop for these things.
Yeah, very true.
Okay, so let's see here. Share. So can you, Amber, can you see it?
It came up. Thank you.
Okay. Okay, so
All
number
right.
one. Anne-Marie, your.
Go ahead. You want to do it?
Okay, the respiratory system is very complex and contains an upper respiratory tract, middle respiratory tract, I cannot talk, and lower respiratory tract. Is it true or false?
False. There's only two.
There you
Yes,
go.
good. The respiratory system has 150 ml of air that is known as physiologic dead space. True or false?
True.
True. Functions of respiratory tract include oxygen transport, ventilation, respiration, all of the above, none of the above.
All of the above.
All of the above.
Letter D. Lung function tests are used to assist providers with diagnosing certain conditions, including COPD, cystic fibrosis, and or atypical pneumonia. True or false?
False.
True.
True.
What?
True.
Oh.
Okay. A negative chest X-ray results may be associated with diagnoses such as dehydration and or viral pneumonia. True or false?
True.
True.
Yep.
When would a CDI specialist query the provider? The type of asthma with severity, type of complications associated with major chest trauma, type of pulmonary edema, B only, A and C only, all of the above, none of the above.
All of the above.
F, right? Influenza is a query that is sent by CDI specialists for specificity of the condition. True or false?
Sure. True.
True. Respiratory neoplasm need to include site, whether it's primary, secondary, or benign, as well as the type of chemotherapy patients may be receiving in the outpatient setting. True or false?
True.
What?
True.
True, yeah.
Yeah, correct. True.
PSI are metrics to help identify potential in-hospital complications. True or false?
True.
True.
Yep. True.
The role of PSI within the hospital setting include identifying problem areas, improve patient safety, focus on hospital-acquired conditions, B and C only, all of the above.
All of the above.
All of the above.
All of the above.
Risk adjustment guidelines for the hospital setting include present on admission status, identification of comorbidities, and severity documentation. True or false?
True.
True. The CDI specialist would send a query to the provider to confirm if a pressure ulcer is present on admission or not. POA. True or false?
True.
True. Common PSI appeals include post-operative AKI. True or false?
True.
True. Okay, HAC are patient complications that develop within the hospital setting. True or false?
True.
True. Several hospital-acquired conditions include air embolism, stage 3 pressure ulcer, surgical site infection, BNC, all of the above.
All of the above.
All of the above?
Okay,
Well,
it looks funky on this thing.
Yeah, it does.
Yeah.
Oh, yeah.
Should be all of the above, I think, but it
Okay.
looks like all of them are listed under A and then they're separate.
Yeah,
Yeah.
and then they separate out. I'm like, oh my God.
Yeah, it should be all of the above.
Okay, so it's all of the above, right?
Right. Correct.
Okay.
Oh, and 16 is true.
Okay, where
Yeah.
are you now?
Okay.
So number
Okay, which question are we on now?
16.
I don't know.
The present and number 16 now, right?
Yeah.
The
Yeah.
present admission is mandatory, so it's true. 17, foreign body retained after surgery indicates the following. If the foreign body is removed during the same hospitalization, it will not be reported as a HAC. True or
False.
false?
It seems like that would be false, but I don't know.
I want to
So
say
it's
it's
true, because if the foreign body is removed during the same hospitalization, it's not reported as a HAC. The patient is discharged and the foreign body is in there, it's reported as a HAC.
Yes.
Okay, just
Okay.
kidding. Didn't really screwed up.
Yeah,
True.
all right.
It's not intuitive. It just seems like if they left something,
Right?
Yeah.
it should be a
I
false.
think that, yeah, they would catch that. Yeah, before they discharged.
Okay, stage 3 and 4 pressure ulcers in sites may include elbows, buttocks, sacral region, and hips. True or false?
True.
True.
It's true. Elbows?
Yeah.
Yeah,
Mhm, mhm,
I count elbows too for
Missed that
contractors.
one.
mhm.
Or would have missed it. I ended up right.
All right. So submitted, and then I will email you the correct 6 units of CEUs. Okay.
Okay.
All right. So and then okay, the survey, please. I'm gonna email
I
it
sent
back
it.
to
I
you.
did it. So it
You
should be
did?
on the radio. Yeah, I did it. It's already like posted.
Okay. All right. Good. So the survey, yeah. All right. Yeah, because it's more important.
Yeah. Understood.
So if you know everybody receive it or no?
I haven't got it yet. No,
Okay.
In your
Let's
spam?
not in my spam.
okay. Let me just do this.
Mm.
I'll just send it again.
I think I
Send
had
it.
one of the webinars where it was delayed coming in as well. I had to do it after the test and it like took an hour or something to come in. At this time it came in fast.
Okay. Let's see. Compose.
Chrissy's gonna resend it to you guys.
Okay. So who did not receive it? Jeannie?
Yeah, jeannie.hucko@icloud.com.
Well, it's just Whitby.nurse.
Oh, yeah, that one works too. I didn't realize I signed up with that one, but that one's just so long.
Okay.
I had listed in your registration form, Jeannie.
I wonder why. Weird.
Debbie, you got yours?
I got my eval and submitted it.
Okay. And how about Diana?
Donna?
Oh, Donna. I'm sorry.
You know what? I'm still fooling around with my test, so I
Oh,
don't know if
What,
I got
what,
it or not, but I'm trying to answer those questions.
okay. All right.
which
You
one
want
are
me-
you on, dear?
You can resend it. I mean, I'm taking the test right now.
So you want us to repeat the answer for you? So
No, I got the answers. I wrote them down.
Ah,
I hadn't gone into the link.
Okay.
I'll get it. I mean, I'm right on the last two right now.
okay.
Okay, all right.
So Whitby nurse still hasn't received her thing for the eval.
Okay. 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 So I'm gonna send it now and see how it's gonna work. Paste. Okay, survey. Okay, send. Okay.
Yeah, I submitted the test, so
Okay.
You should be
No.
having,
I don't see any email from me for the,
Val.
oh, let's see. Yeah, you have submitted I've got the proof that I submitted it.
Okay. But I just emailed the eval, so.
Okay, yeah, I don't see any eval yet.
Okay, it will be Donna and Pat. Ah,
I got the evaluation.
okay, good.
Yeah, it's just probably a little delayed.
Okay. If you could send us to us, appreciate it.
And what?
If you could do it and submit it, that would be.
Got the eval yet.
Mm-hmm.
get it. So yeah,
But I
wait a few
will.
minutes here.
I mean, as soon as I get it, I'll submit it.
Yes.
But I
Uh-huh.
just don't see it here.
Okay. Well, just email us if you didn't receive it. Jeannie, you receive it, right?
I have submitted it. Thank you so much.
Okay, thank you so
Hey,
much.
okay.
And I will, like I said, I'm gonna send you the 6 hours of CEU and
Thank
wait.
you.
Okay.
Sounds great.
Okay. Thank you so much for attending.
Yeah, Donna. Hope it was helpful for you,
Great.
Donna.
Just
Thank you, Donna.
gotten it.
Bye bye. You all take care.
Okay.
Bye, everyone.
Hi, Jeannie.
What is this? Anne-Marie?
Yeah,
Okay, don't hang up yet. So,
no, I'm not.
okay, let's see here. I don't know what happened here. Okay, so what is this launch picture in picture mode to your
The
meeting
launch picture in picture, it gives you the listing on the people,
of the
you know, and-
people. Okay.
yeah,
So
that are part. Yeah.
so let's practice on that. How come it didn't how come it
Oh, what,
didn't
yeah, I don't know what
presentation?
occurred here.
Okay, let me
Um,
try and then you try. Okay, so let me try first this one here.
Still sharing though. You want to delete
Yeah, I
it.
still
Okay,
don't
you
have
just-
the eval. So,
Oh, Donna, you don't?
no, it hasn't come in. I'm still looking, but I did submit the test and I got
Okay.
and I just haven't got the eval to send you guys.
Okay, hold on.
Okay.
Let me copy the link. And yours is
Anna.fielden at,
at yahoo.com, right?
Yahoo, yeah.
and I got everything else. I just didn't get that part of it.
Okay, hold on. Let me just double do that.
She's gonna try another way. Chrissy's gonna send another way to you, Donna.
Yeah, I got the first
Oh.
one when
Mm-hmm.
you confirmation of the class and stuff.
Okay, here.
Yeah. Okay.
Okay, so I am sending you now. The title would be evaluation. The subject, I mean. Okay, so let me paste the link. Paste. Okay, and send.
Yeah, I don't know. Maybe because I didn't take the test right while you guys were going on it.
Or can you check your spam? Probably it's in the spam.
Oh, you know what? It
Great.
just came up. It just
Yes,
came
up.
up.
Okay,
Oh, perfect.
So I'll
perfect.
submit it, and then you guys, thank you so much for your education.
Thank
Oh,
you.
Donna, I hope it was helpful for you.
Oh yeah, I'm gonna order more of these classes from you. Thank you for doing
Thank you,
that.
and we'll update you on our upcoming classes because you're already in our mailing list, so we'll let you know. We'll
Yeah,
send them.
I had done, I think, a respiratory failure from you, but I never got any eval or anything, and that was probably over a year ago. But
Oh.
a girl I work with had told me about you, and that's the first time I've ever listened to a live one. Thank you
Yes.
so much.
Yeah, you're welcome.
You're welcome.
So we'll see you again next time.
Thank
All
you.
right, Donna, take care. Enjoy the rest
you.
of your weekend, dear.
Thank you.
Okay.
Bye.